Recording in
Hello,
progress.
and a very good evening to all the viewers. This is really a present moment because India won an Olympic gold, that too in javelin for the first time. And we are really pleased to share this information with everyone. And today, to continue with our series of eGurukul, this is Dr. P.C. Mahapatra with you again, a teacher par excellence. And he is going to deliver his experience on the surgical complications in obstetrics and gynecology. And he'll try to give you tips and tricks in solving the dilemmas. So this is the 16th episode in continuation. And we wish that there would be many, many more with all the, good wishes from the viewership and blessings of Dr. P.C. Mahapatra. So, sir, we request you to please start your deliberations.
Thank you, Dr. Diwan and whole team of Zuventus for this endeavor. I think you have rightly told that, yes, India is proud of that, and you have given a very good news. And I hope India will celebrate that. Never before it has got it. And I'm not an Olympiad, but I'm basically a teacher. And that's why I will focus attention to the teaching part, and especially to the subject of obstetrics and gynecology, which I'm continuing for the last of 15th episode. And now, today, I welcome all of you, all my viewers. As before, I think I'm really glad that the viewers, my fellow gynecologists and my students, my colleagues and everybody for this episode 16. And it's a Zuventus initiative. As usual, we go for the common theme about surgical skill transfer and solving clinical dilemmas. And this time I have taken a different, I think, aspect and bringing greetings from the place of Lord Jagannath. I think this particular episode is dedicated for the complications, the surgical complications in obstetrics and gynecology. And basically, I will focus my attention to the gynecological part because I've already discussed many things on obstetrics, particularly the post-cesarean complications in my previous episode. And these surgical options, the tips and tricks and solving clinical dilemmas will be really dealt with, particularly for common gynecologists facing everything for that. Is it not audible?
It's audible, sir. Slideshow, please enter slideshow. Yes.
Okay. Hello?
Continue.
Hello? Shall I continue?
Yes, sir.
Yeah. So this particular episode, I will particularly devote the complications which I have also faced in my life over the past few decades, and with reference to the gynecology and the various surgeries and related clinical dilemmas associated with it, so that this will be a learning for everybody for that. Well, it is said that there are 3 lies in medicine. First lie is a medical statistics. Second is complications of surgery. Third is results of IVF. These are the 3 lies in medicine which all gynecological and surgeons and obstetricians must have realized this. And it is the usual practice to hide the complications and project the success. I think this session is completely reverse. Absolutely, unless we lessons learned from the complications, we cannot progress. And that is the main purpose for which, as a teacher, I will share many of my experiences and how to deal with that. And all of you must have faced the same thing in your day-to-day practice for that. Well, there are people who say that I do not face complications or I have not seen surgical problems. I'm a professor for last 30 years and I have not faced any surgical problems for that. I always level them either not doing surgery at all or the greatest liars ever possible. So this is the inference. So everybody, those who are doing a surgery must have some face some complications for that. But you have to learn it, you have to prevent it, and you have to reduce the complications. Minimizing complications and maximizing results is the ultimate motto of every surgeon, every gynecologist for that. Now today, I will have a focused areas on these particular three main aspects, because surgery, perioperative, is usually preoperative evaluation counts, intraoperative events, what are the problems that can encounter and how to prevent and manage the complications, and post-op management. These are the three focused areas I will just enumerate, and followed by some of the videos which I will just share with you. Now coming to the pre-op evaluation. The pre-op evaluation, first and foremost, is the genuinity of indications. Surgery cannot be done at your own whim. It is not the mood of the surgeon, it is the need of the patient. Never with the mood of the surgeon. That genuinity of indication is absolutely necessary, and you should be more scientific and rational whether surgery is indicated or not. I have earlier told that it takes 5 years to learn and do the surgery, but it takes 25 years to learn and not to do the surgery for that. So genuinity of indication is very, very important. Then about the second important considerations, type of the procedures. So pre-op evaluation will vary according to the type of the procedures. There are various surgeries in gynecology, which I will enumerate. The type of procedures also is variable. And one of the very important thing is pre-op counseling. The pre-op counseling is absolutely necessary in the present era when medico-legal problems are there, when the beneficiary are literate, educated, and therefore they should be well counseled about the pros and cons of surgery. And assessment of pre-op surgical risk is there, because we want absolutely zero mortality and absolutely close to 100% reduction of the morbidity part. And therefore, a pre-op surgical risk assessment meticulously has to be done. Then the pre-op planning. As a surgeon, majority, I always tell my students that you lack in planning. So surgical planning is absolutely essential, not to have a only mindset, but it avoids many, many complications for that. You mentally be prepared and take many steps before the surgery, then adopting and deciding then and there with the knife, you decide for that. So there are many, many things. In particular case should be individualized, and you should find out what problems you should encounter in that particular case. And therefore, pre-op planning is very, very important for that. And therefore, we see a simple example I'm giving, that in difficult cases, in complex cases, complications are less. Whereas in a very simple case, complications are more. This is just because of overconfidence and lack of pre-op planning. So therefore, the pre-op planning merits a consideration before the real surgery begins. The need for ancillary help. Don't have an ego that I will do everything for that. And in many situations, you need help of people. A GI surgeon, where you anticipate that there could be a problem, previous surgery and all that, and you anticipate that there is a need of GI surgeon which can be associated with it. And this is important. Urologist, neurosurgeon, in some cases we see that where we anticipate the problem, we just call them to be present there and take help of them. Or when you face the problem, you call them at their services at that particular level. And pathologist is also important, because the pathologist, many people must be thinking that in surgery what pathologist will do. Yes, they have a role, because imprint smear and the frozen section biopsy plays a very important role in deciding for the next management and surgical protocol for that. And therefore, pathologist. And at last, critical care specialist. You need that some of the cases which are high-risk cases for surgery as well as anesthesia, they require a critical care backup. A critical care specialist help could be very, very important. So you need a help of other people and all that. Even your own colleague, you take help of your own colleague. I usually at this stage also in a difficult cases, I call one of my friends to assist me and be with you in the surgery. So that I have found out that builds up the moral strength of the person surgeon. When another person is there, he feels more confident about it. Even if he's capable, a person close to him and who can assist and who can do that, a joint venture, I think that is nothing like it. No question of ego there. So for the benefit of the patient, These are the ancillary help you can find out for that. Now, coming to the genuinity of indications. There are many unindicated surgery. You go, everybody must have seen that the unindicated surgery are many. And there are patients who also say that, yes, I have got ovarian cyst. You operate for that. But this is a case of polycystic ovary. And the radiologist has given a report that there are multiple cysts in the ovary. It is not 10 to 20 millimeter. They don't write that one centimeter or 2 centimeter. 10 to 20 millimeter polycystic ovary, that unindicated surgery is there. And the common indication, common unindicated surgery is hysterectomy. Fortunately, we have improved a lot. I can say that there was a study 5 years before. What are the unindicated surgical intervention in country like India? The first came as coronary care, coronary intervention. So coronary intervention is the first. And the second was the hysterectomy. Third was joint replacement. Now I think the hysterectomy has come up in a third position, whereas coronary care and joint replacement are still there in the first and second position for that. So we are little better, but still there is you must think that there is an indication of hysterectomy, do it. Otherwise, find out some alternative methods for that. So thinking of alternative options is important, even if there is some problem for that. Find out any non-surgical methods for that or not. Therefore, luckily, we can say that there are many methods like MRG focus ultrasound, like the vascular surgeon and the uterine artery embolization, and many other alternate options are there also. Thermal balloon and other thing for that, genuinity of indication. So alternative options to hysterectomy has to be found out for that. Now, the type of procedures. We divide, as a surgeon, we divide into minor versus major. Minor is just a short procedure. Major is a long procedure, and ultra long could be some radical procedure for that. Fortunately, out of all the surgical intervention in gynecology, it's not like other procedures like orthopedics, other procedures like neurosurgery, other procedures like the other radical procedures take a longer time. Accepting the uterine transplant and other thing, the time taken is absolutely within the reasonable range for that. And minor versus major is according to the duration of surgery, according to the pathology, and we consider that this is minor with a local either local anesthesia or with the short anesthesia, intravenous anesthesia like a TIVA, pentothal, or the propofol, that we can do it finish it within 5-10 minutes. It's a minor surgery, but major surgery involves a lot of, it takes a longer time, it takes a longer surgical technique is different and more complex procedure. Diagnostic versus therapeutic. Whether you're going for a diagnostic, say for example, a diagnostic hysteroscopy, diagnostic hysterolaparoscopy versus a therapeutic surgery, lap surgery for that. And diagnostic versus therapeutic, elective versus emergency. You have to decide elective versus emergency. The output, the methodology is completely different in these two varieties. Benign versus malignant, you must be more radical. Minimal invasive surgery versus conventional. Single versus concomitant procedure. I think these are the cases. Joint surgery, a combined procedure. Suppose somebody is doing a hysterectomy and at the same sittings you find that there is a gallbladder, cholelithiasis. In collaboration with the surgeon, the surgery can do, the surgeon can do a lap call and you can do a hysterectomy, either vaginal or a lap hysterectomy you can do. And in a minimal invasive surgery, both surgeries can be done in one particular sitting so that the convenience of the patient, both physical, financial and everything would be solved for that. But ultimately selecting the correct modality is important for that. And during the last few decades, we have changed a lot about the different types of surgery from conventional to minimal invasive. I think in the near future and in the future also, the dynamics of the surgery may change in a drastic manner so that the new technology will come and artificial intelligence will come, and there could be different new dimensions for that, because we have seen over decades how the surgical principles and the surgical techniques have evolved and changed over the years. Now, pre-op counseling. Pre-op counseling is a major now need today, because there are two aspects. One is the patient is literate, they are conscious, and second is about the the medical legal problem. So these particular thing, now counseling is important. You must tell that what are the procedures you do, what are the if you build a confidence and rapport, I think 100% of the medical legal problem will be solved. That is the lacunae of us in not giving a pre-op counseling for that. Assessment of pre-op surgical risks. In the assessment of pre-op surgical risks, I have divided into one of the patient's profile and procedural profile. The surgical risks are different in the two aspects, in the two profile, and you have to assess that. Say, for example, patient profile, what are those? Age. Age is a very important thing. And marital status, fertility status, obesity. These are all patient profile which needs a special consideration as far as the pre-op assessment for that. And comorbidities, particularly the cardiac disease, hypertension, diabetes, kidney disease, respiratory disease, liver disease, hematological problem, psychological problems, and infections like HBsAg positive, HIV positive, and now in the COVID era, COVID-19 viral infections positivity. So therefore, the patient profile is important on all these aspects, and assessment has to be done preoperatively, meticulously for that. Procedural profile. Procedural profile also varies according to the different procedures. The vaginal procedures, even in vaginal procedures, all the different vaginal procedures have carrying different risk for that. You have to assess the preoperative risk. Abdominal procedures, laparoscopic procedure, robotic procedure, hysteroscopic procedures, complexity and extent of the disease. If the disease is complex and extent of the disease is diverse, I think these are all procedural profile you must record and have a pre-op assessment for that. And what are the exact procedures you do it? Also, depending on the procedures, the risk also varies for that. And say, for example, simple example I'm giving. Suppose you are doing a hysterectomy and patient is asthmatic, COPD, asthmatic and all that. The choice of anesthesia will be more preferably regional anesthesia than general anesthesia. So somebody does do a lap hysterectomy and converting the patient risk subjecting to general anesthesia, I think reconsider that, whether the same risk can be abolished by changing the anesthesia and all that. Radicality of the procedure. Procedural profile, radical. If the radical surgery procedure, not only the time is important, but the risks are important because you have to do an extensive dissection of that. And therefore, this radical procedure pre-op assessment is very, very important, including the MRI and all that. We do it for extent of the lesion, for lymph node assessment, for the possible metastasis. This is important. And of course, the concomitant procedure. If you're doing a combined surgery, these are the procedural profile carries more risk for that. Now, next is pre-op
Recording in progress.
Pre-op investigation. What are the pre-op investigations? You know, day in and day out, you must be doing all sorts of surgery, both minor, major, ultra major, and all that. And therefore, pre-op investigation, some basic pre-op investigation is necessary. Pre-op anesthetic evaluation is also necessary. You ask your anesthetist today, there is a lot of importance on pre-anesthetic evaluation. And therefore, pre-op anesthetic evaluation is very, very important. Then surgical planning, as I've already told, you cannot ignore the surgical planning. You cannot say that then and there I will do a planning for that. And pre-op preparation depends on the fitness for surgery. Suppose you are doing investigation, anesthesia fitness, surgical fitness, whether she is fit to undergo this particular procedure or not, fitness for surgery. Bowel preparation. Luckily, there is a change in the system of the bowel preparation. Gone are the time when routine anemia was there, bowel preparation in all types of surgery, major surgery for that. Now, the bowel preparation will be restricted to some of the surgeries which may likely to be landing in complications of the GI tract. So these are the cases where meticulous bowel preparation, say for example, complex perineal tear, RVF, fistula repair, all these, or extensive endometriosis or adhesions involving the bowel, or radical procedure. We do have simple bowel preparation. It's not that for 3-4 days anemia and nothing by mouth and all this. We do not do it nowadays. We just even with PEGLEC is enough for that. And normal surgery bowel preparation routine is not, aggressive bowel preparation is not routinely important. Skin, same thing. Skin preparation, shaving or clipping, these are the things. Thromboprophylaxis. Now, this is important. You must assess whether there is a need for thromboprophylaxis or not. Because in pelvic surgery, thromboprophylaxis is important. In obese, Thromboprophylaxis is important. In pregnancy is important for that. So therefore, and in known DVT, thromboprophylaxis is important. So select that which are the category, and you will find out that whether the patient is needing thromboprophylaxis or not. Antibiotics, prophylactic antibiotics is absolutely essential, and the recommendations, the evidence base says that 1 hour before the surgery, give a dose of antibiotics for that. Hemorrhage and transfusion. If the patient is not fit, anemia, building up of the patient, and then do it. Unless it's an emergency. For elective cases, you build up the patient by doing it. Earlier, we were building up the patient by repeated blood transfusion. Now, say no to blood transfusion. In a routine case, in a non-emergent case, in a the patient where there is active bleeding is not there, you can build up the patient by alternative methods. And today, now, the parenteral iron is there, you build up the patient parenteral iron, give hormones to stop the bleeding, and do the surgery, shift the case for at least a couple of weeks, and then when the hemoglobin is, then you do it. If the patient is absolutely in emergency cases, radical cases, the oncology cases, there you build up the patient. Rapidity is important, rapidly. You can't defer the surgery for long weeks for that. And of course, the chronic medications. What are the medications he has taken? Whether it is a long-term treatment of steroids, aspirin, clopidogrel, all these has to be taken care of. And you must see, to take the history, psychiatric medicines. And these chronic medications is also to be looked after in the planning for that. Otherwise, in the last moment, you will be really landing in disaster. Now, pre-op investigations, I won't detail about all pre-op investigations, which everybody knows that. But with special reference, nowadays, a COVID era, every surgery, we do a COVID-19 test for that. And there are some reports in the COVID era that surgery augments surgery in a COVID positive, previous COVID positive cases, recent COVID positive cases, the risks are more. Maybe that could be, there are many reports which are going on for that, and some you cannot ignore this particular case, but at least for these particular, if it is a non-emergent case, you can prolong it after because post-COVID status, post-COVID other illnesses are more often, we do not know, so that we routinely do a COVID test for hospitalization for other regions of your hospital, your staff, and for the patient herself, that you do a COVID test, and COVID negative patients you operate it. But in an elective case, you can postpone the surgery if at all there is a recent COVID infection for that. Now, urine culture sensitivity, not in routine cases we'll advise, but in vaginal cases, particularly for prolapse, when there is a cystocele, there is a pre-existing urinary infection, they're more likely to get a urinary infection. Therefore, urine culture sensitivity has to be done. Cardiologic evaluation is again routinely done for that. But a case I will again advise, a recent sonography, CCT or MRI, this is important in some cases, and tumor markers. This is important in some cases where previously you have seen about 2 months back, recent sonography, suppose there is a lesion, what is the status now? You can repeat it in some cases for that. And if need arises, you do it, a CCT and MRI, and then tumor markers for that. Now, pre-op anesthetic evaluations. Pre-op anesthetic evaluations, the clinical evaluation. You cannot ignore the clinical in the era of gadgets. Clinical evaluation is important. The anesthetist must see. And investigations, all these additional investigations subject to the particular indications of the case, you must do it depending on the type of procedure, and he will assess the risk assessment. Even in known cardiac also we do that, and the anesthetist will assess the risk of the cases in known cardiac, in comorbidities, all these risk assessment, and the preparation of anesthetist is important prior to surgery for that. Need for post-op IU setup. These are the cases. There could be need of post-op IU setup. Perioperative pain relief is important. Perioperative pain relief has to be considered. And of course, again, the counseling by the anesthetist. So counseling by the anesthetist also there. If before preoperative period, she will counsel with the patient. She will talk with the patient. That builds also a confidence. And when is the panicky situation for surgery? I remember in anesthesia checkup and all that, pre-op anesthesia, why I told that clinical is also important. I was just reading in one article where in one of the very famous hospitals, the pre-op anesthesia room is in the fourth floor. In the fourth floor, and any patient who is to undergo the pre-op anesthesia checkup has to climb up and avoid the lift. And this is the purpose for which they have taken. If the patient can comfortably climb without any symptoms to fourth floor, it implies that functionally is okay for that. And you can absolutely assess. So this is an estimate that clinically there could be find something, the changes in the PQRST wave in ECG. But she's functionally absolutely normal. She's climbing upstairs for fourth floor for that. That is the purpose for which I could realize that. And surgical planning for the surgeon, mindset, again I will say that mindset, anticipating the problems each and individual are different, understanding the anatomy and altered anatomy. This is important. You know the surgical anatomy, but altered anatomy is important. The altered anatomy, either a congenitally altered anatomy or by virtue of previous surgery, there could be an altered anatomy. You must know what could be the altered anatomy. And therefore, the technique, and there last is the techniques and skill. Skill is a paramount important surgical skill. And again, I emphasize that there should not be any ego, need for ancillary help. It has to be done for that. And you must find out in difficult and complex cases, take help of your colleague. And there is no ego that I am all in all, I can do everything for that. Now, intraoperative complications, what are those? Those are expected. Anesthesia related, drug related, and surgery related. These are the three main things in intraoperative complications. Anesthesia related, common is hypoxia and hypotension. Common is hypoxia and hypotension. The hypoxia has to be, oxygen support has to be given, and identifying the hypotension, preventing it is much more important than complications, landing in complications. I think a little vigilance could serve many purposes for that. Once it goes to irreversible phase, even we put it in ICU and all that, you cannot rescue the patient. Total spinal, aspiration in general anesthesia, incomplete recovery or delayed recovery. This is very common. And in a BG center, in a BG hospital, that incomplete recovery or a delayed recovery. And before the incomplete recovery, patient is transferred to the ward. And that creates a lot of problem. That will give rise to a fatality. Awareness and pain factor. Anesthesia should give, it's not that pain relief. It's not that the anesthesia, you give it and the patient will not complain of pain. For awareness also, she should not have an awareness that many patients say that I am absorbing whatever you are talking. I know whatever you are talking for that. Awareness is there for that. And there could be pain. Internally, there could be pain. So pain factor and awareness has to be also addressed by the anesthetist. Drug-related anaphylaxis. Every one of you must have faced anaphylaxis, as me also. Lignocaine, bupivacaine toxicity, adrenaline and vasopressin. Vasopressin was really a panicky for gynecologists. And now vasopressin is commonly used, and therefore there are many surgeons are afraid of using vasopressin, and there are many reports of fatality of after vasopressin for that. But believe me, this is preventable if you take a little vigilance. Surgery related, primary for the surgeon is hemorrhage. We have seen a lot of changes in the arrest of tackling hemorrhages. There is a lot of changes from the beginning, 15-20 years back. What was there? Now there is a complete change. The electrosurgical unit has given a good, I think, drastic change in the hemorrhage for that. And no more we are taking a bite and we are suturing every vessels for that also. So hemorrhage, injury to adjacent organs. I think even if you know the altered anatomy and the anatomy, if you are not meticulous, injury to adjacent organs, that bladder, rectosigmoid, intestine, stomach, ureter. These are the main organs which is likely to be affected by the surgeons, by the gynecologists. So gynecologists are very much afraid of anteriorly the bladder, laterally the ureter, posteriorly the rectosigmoid, and superiorly the intestines. I think they are very much afraid of that. And therefore, these are all likely to be affected, likely to be involved in your process of pelvic surgery and intraoperative complications. You must first of all, you tackle not to create any complication, prevention of the complications. Then, if at all there is there, then the appropriate management of that particular setup has to be done. So intraoperative complications in nutshell, for the surgery, for the surgeon, hemorrhage is important. For the anesthetist, hypoxia is important. So oxygen support to the anesthetist and hemostasis to the surgeon. These are two very important things. If these two are adopted, majority of the intraoperative problem will not occur. Prevention and tackling pelvic hemorrhage. This is a chapter by itself. There are a lot of changes in the hemorrhage, pelvic hemorrhage, as I have already told, identifying what are the problems. So identify there are many preoperative factors that is likely to give, so they give rise to pelvic hemorrhage or not arresting the bleeding. So identifying the preoperative factors. Patient has already, so on drugs, medications, she has not stopped clopidogrel, aspirin, all these. She's suffering from some of the hematological problem. These are the cases where pre-op factors is there and you are doing a surgery. Even surgical thing, a case where there is the leiomyosarcoma or a malignancy case, a vascular tumor. These are the cases where the case itself gives rise to a lot of bleeding and pre-op factors. Even once upon a time, the vaginal surgery, any vaginal surgery is a bloody surgery for that. I remember when I was a postgraduate, the vaginal surgery is a bloody surgery, and all vaginal cases, the anesthetist used to advise in a pre-operative, pre-anesthetic evaluation to sufficient unit of blood to be kept ready for that. Now the change is there. The surgical skill has developed. Electrosurgical procedures has facilitated the arrest of the bleeding of primary bleeding for that. And therefore, even if with that, pre-op factors are important. So meticulous dissection in correct plane. Now the skill important. Skill of dissection in a correct plane and avascular space and fossa in pelvis. In a pelvic surgery, pelvis, luckily there are very, very important avascular fossa and space. And these has to be identified. Knowledge of the space is important. Knowledge of the fossa is important. You go through the right cleavage, the bleeding will be less. Gentle tissue handling. Tissue handling should be absolutely gentle all throughout. This should be a basic surgical philosophy. Then in gynec surgery, hydrodissection, infiltration of dilute adrenaline or vasopressin, we have seen that these are the cases. Hydrodissection separates it. Not only it gives a good space and identify the fossa, but at the same time, the hemostasis, the bleeding is less, and particularly aided with the adrenaline dilution or vasopressin combination, as you see routinely in myomectomy. This is mandatory for that. Use of electrosurgical gadgets, I have already told, the bipolar and all. One episode I have dealt with the electrosurgical procedure, how to control the bleeding. Suturing and clips as and when required. And the three principles I always say, pack, press and pray. 3P. And then the fourth P, PC Mahapatra, you remember. So the pack, press and pray. When there is a generalized oozing for that, how much hemostasis you can maintain with the coagulation for that, particularly in the vitals, over the vital structures. So pack, press and pray. These three will be there. At the end, you see after 5 minutes, whole thing will be dry. And don't be hasty in that. Don't be very much perturbed in that. This principle you adopt in generalized hemorrhage. Systemic tranexamic acid. Now, this is a very useful drug, either a pre-op or intra-op. There are a lot of studies. Here by FIGO also have done a lot of study. Arul Kumaram has done a lot of studies on this tranexamic acid pre-op or intra-op in arresting bleeding for that and prevention of the bleeding before surgery or during type of surgery for that. Local hemostatic agents, like there are many agents, either a chemical agents or a mechanical agents, even the mop, even the gauge piece, that mechanical could act also for that. And chemical agents, there are various chemical agents and other materials like Surgicel, and many companies have found out that this is the agents which can be used by the local thing. You spray it or just sprinkle the powder. This acts on the local hemostatic agents apart from the gel foam or other thing which comes as a mechanical thing. Exposure, this is important for the dissection. Exposure, visibility, assistance, and anesthetic help, relaxation. I think these are all important to tackle pelvic hemorrhage for that. Need for volume replacement, plasma expander, and blood components. The anesthetist must assess during the time of surgery that what is the blood loss, and you are not able to, you are focusing attention to the surgery, and the anesthetist to assess whether the need of replacement is there or not. And therefore, right moment she should say that yes, in emergencies, you should have a requisition of blood and then intraoperatively you can transfuse that. Monitoring patient important is a monitor of the, now we are fortunate. Gone at the time when the monitor were not there, simple by the pulse, the anesthesists were observing. Now I think monitor is a common place for everyone, and it's absolutely a good sign. Monitoring of the patient by the different multi-para monitor is there. You can fit it, and intraoperative, not only intraoperative, post-operative also. In some cases, or the cases where it is necessary, you do it for hours to days. There is not a problem. Post-op management. Coming to the post-op management, this is important. Immediately after surgery, don't ship the patient to the ward. This is a lesson which I have seen. I will just share my experiences for that. Recovery room. Even if in a small hospital, like 10-bedded hospital also, you make one bed in the close to the OT as a recovery room. And remember, may it be a minor procedure, may it be a major procedure, you keep the patient for at least half an hour there, and therefore after complete recovery you transfer that, and therefore in that particular case you can have a monitor, because you have the nursing personnel and other thing, they may not be competent enough to measure the blood pressure, pulse requirement and all that. You can put a monitor where pulse, blood pressure and SpO2 can be recorded for that. So essentiality is the recovery room and monitoring for that. Even medical colleges also, when I was there, I think at that time recovery room was absolutely essential, but hardly there are places where recovery room was not, recovery room was there. And this is mandatory for the safety of the patient. Pain management, post-op pain management, the anesthetist, you ask with the anesthetist, and don't say it mechanically. You will give the analgesics as and when required, paracetamol as and when required, the other pain relieving drugs, tramadol and other thing and all that. But starting from the PAC to the epidural or continuous epidural, pain management is a subject of the anesthetist. Nowadays, the opioid pain relieving drugs are available. You can use that for a long-term pain relief for that, apart from short-term pain relief by injecting the sensorcan during the site of surgery. This is extended pain relief. Subsequently, as long as the patient is there, she should not have a pain and pleasurable surgery for that. Monitoring vitals, I have already told. Pulse, blood pressure, urine output, and very important is urine output. Many people say that yes, if urine is normal, that is a very significant factor that the functions are normal. It is not the BP alone, the pulse, the tachycardia or bradycardia is more significant for that. And of course, the sensorium. If the altered sensorium is there, you must think thrice for that and call help for other faculties for that. Fluid management is a different chapter by itself. I don't want to explain about the role of colloids, crystalloids, blood transfusions and all that. But fluid management during the perioperative period is absolutely important. Now, in a minimal invasive surgery, I think the duration has been drastically reduced so that the fluid management requirement is less nowadays. Oxygen support, wherever you need to have a oxygen support, perioperative, postoperatively, some patients do have oxygen support and you give it. Bowel and bladder care, general well-being. Just talk to the patient, and general well-being is important. And any specific complications identified, you just immediately don't ignore and just intervene to prevent and manage the complications for that. Now, next part, I will just focus attention with this knowledge in the preoperative, intraoperative, and postoperative scenario and care. We will shift the next half to the clinical scenario and what are the dilemmas. And this is all which I have faced, and I want to convey to you, my dear viewers, for your knowledge, your information, and my upgradation. Because if I get a feedback, I will upgrade myself. Till my last breath, I have to upgrade in medical science. And there is no limit of learning, and there is no age for learning. Every age you have to learn every day. As a surgeon, everything, every day there could be some unpredictable events which you must convey. Now, case 1, 48 years, para 3. Is a case of pelvic endometriosis, hist of lap surgery twice, and therefore one of my students attempted for laparotomy. And it failed. It can't enter into the peritoneal cavity because of the adhesion, or the uterus is pasted to the intestines, gut and omentum, and abdomen closed. And it was done 3 months ago. She has a persistent pain, abdomen and menorrhagic cycle, adenomyosis, as you know, and sonographic evidence of adenomyosis with chocolate cyst ovary, right. It is not relieved with medication planned for abdominal hysterectomy. I always say to my students that this type of cases you must be exposed to this type of cases, and a middle level gynecologist has to be more subjected to this type of cases, not only to build your confidence, but to learn many things out of these cases. Just to do hysterectomy, lap hysterectomy in a simple case doesn't solve the problem. These type of cases, there is a lot of learning and lot of learning of skill and dissection. And because these are cases where problems can be encountered at every step, starting from opening till closing. Now, therefore, it needs a surgical planning and counseling. Again, patient has to be involved. Patient has to be informed what should be the consequences of the procedure. Need for help from surgeon friend. Therefore, if this particular case, you ask your surgeon friend, either he will be there, or at times of need, you call at a particular situation when things arise for that. And need for pre-op requirement of blood. These are the cases where you require a blood. Otherwise, don't operate with blood transfusion. Minimal blood transfusion is important unless it's an emergency, unless it's a blood loss, acute blood loss, unless it's a malignancy. These are the three cases where blood I will give it. Otherwise, I will try to do it without blood. And these are the cases where, exceptional cases, where there is a risk of the bleeding and all there. Either pre-op require you bring a blood, at least multiple units of blood, or at least a donor, arrangement of the donor. I keep ready for that. You don't order that you transfuse it, and donor must be ready for that. Now anesthesia is given and spinal bupivacaine has been given, and after 7 minutes of the bupivacaine, there is hypotension and BP fall to 70. These are the cases. This is usual sequence of events in a spinal anesthesia, and the variable times are there. Some hypotension immediately within minutes, some hypotension in a delayed, and some also bupivacaine lasts for a longer time. Even in the ward also there could be hypotension following bupivacaine 2 hours after that also we have observed. So this is a very important thing. A common thing about the regional anesthesia is hypotension, and therefore particularly spinal anesthesia. Epidural doesn't have that, but spinal anesthesia do have that. And these cases, what are the surgical steps? Very important surgical steps is use of myoma screw. Remember, the myoma screw has a lot of importance here. I have seen during my postgraduate or during my earlier cases, when the simple hysterectomy is done, how to hold the uterus, we ask it. With the two cockers on either side, the upper pedicle, you hold it and lift it. But here nothing is visible. Maybe that the entire surface of the uterus or a fundus, one part is visible. Rest everything is covered with adhesins. So there the myoma screw fixation is important. You can elevate it. Fixation and traction is important. And that is also facilitating adhesions of the omentum and the gut in the posterior or bladder in the anterior. So this is a niche. Then plane of dissection closer to uterus, always closer to uterus, less damage to the vital structures for that. So this is important. And first of all, mobilization of the uterus. You have to mobilize the uterus completely and with special precaution to bladder and rectosigmoid. This is important. In endometriosis, the posterior part is more often involved, and therefore the whole of the rectosigmoid is involved, and there is a previous surgery for that. And therefore, take special precaution in going closer to the uterus and posteriorly, and therefore you are free from the rectosigmoid. And adnexal removal. At times it becomes very difficult in a previous surgery, where retroperitoneal dissection. You go retroperitoneal dissection will facilitate the dissection much better. You enter into it and dissect the retroperitoneum, enter into and you can see clearly the ureter, the great vessels, and then dissection retroperitoneally. You can do it posteriorly, dissection for that, and therefore eliminates the risk of injury to the vital structures. Vessel sealer, a boon. Definitely a vessel sealer is a boon for these particular cases, and therefore the vessel sealer, you use it, a bipolar is more preferable, and the vessel sealer, but identify identify the structure before applying the bipolar vessels. It's not that there could be a complication of the electrosurgical burns also with that damaging to that. A bipolar can cause that. But this is all important for that. And therefore, you can see that how difficult it is to enter into the peritoneal cavity on this video. At last, we have entered into it, and we can see that the whole of the uterus. Now I can put the myoma screw. Only the fundus is visible. Nothing was visible for that. You put a myoma screw and give a traction, and therefore this will facilitate the surgical dissection also and procedure also. This is important. See how it is fixed. Everything there is a fixed. Everywhere there is a fixed thing because it's a big adenomyosis of about 16-18 week size, and then after that you just find out. Along with that, there could be myoma, and these are the cases where you just dissect it. There is adhesions in the anterior part, in the uterovesical, adhesion in the adnexal region, and posteriorly there is adhesions of omentum. You go very, very meticulously separate the omentum from the omental adhesion to the posterior part, and just while using the electrosurgical instrument, be certain that you are sure that the organ is nothing. You see there's anteriorly how much is the uterovesical pouch is adherent. Luckily, the contrary to the belief that the posterior segment there is a lot of adhesions. Because of the previous surgery here in this particular case, there is also anterior adhesions and posterior adhesions for that. This is the posterior aspect. You can see the rectosigmoid, how it is adherent, and go to the closer to the uterus. As I have already told, closer to the uterus, and finger is the best dissector ever possible for that. And here the chocolate cysts are being found on the lateral aspect in the close to the uterosacral. But remember, closer to the uterus, finger dissection and meticulous traction will really alleviate and relieve it from the rectosigmoid. These are all grossly adherent to the rectosigmoid, and therefore these are the cases where vessel sealer can be a boon for that. So these are the adnexa which is being lifted, and this is otherwise I would have gone for the retroperitoneal dissection for that. So, but the posteriorly whole of the rectosigmoid is adherent for that. But take very, very important care, because prevention is important. Don't try to create the rectosigmoid injury. You always try to prevent it. Lot of things could be solved for that. And this is how you do this particular case. And if you're going for a laparoscopic hysterectomy also, in this particular case, a meticulous laparoscopic the surgeon will do the same philosophy. Philosophy is same, and the dissection is mainly use of the electrosurgical equipment or the ultrasound equipment, and these procedures, surgery, the philosophy is same, but the technique is just different for that. Now, managing the complications, again, hemostasis, this finding cleavage, avascular space, I've told, use of bipolar coagulation, as in this particular case, bipolar I've used it, and then cutting by the bipolar seizure, and then going close to the uterus, bowel injury, and main thing, you have to have an hemostasis, apart from the coagulation, the primary bleeders. If there is a primary bleeders, you have to either seal it with the vessel sealer or suture it. There is no harm in that. Whatever is feasible, you do it. And bowel injury, the small gut and rectosigmoid. If you try to prevent the bowel injury, if you take a proper step as the facilitating factors which I have mentioned, you are very, very confident that you are not doing complications. But if at all there is a small gut injury, if at all you find a rectosigmoid, the primary repair, the colostomy, you have to define whether you do a colostomy or a primary repair. I think more than this depends on where the location of the injury is there in the rectosigmoid, the length of the injury is there. That is important, determining whether it can be done by primary repair or colostomy. Majority can be done by primary repair of the cases when there is an extensive multi-segment injury or length more than 5 centimeters. Then only you do a bypass, the colostomy, and then do it for that. Now, use of vessel sealer, you can see here, the use of vessel sealer can avoid this particular thing, avascular and hemostasis can be maintained for that. And you use the various vessel sealer which is there, electrosurgical equipment, During my episode of electrosurgery also, I have told that how this is facilitating the surgery. The technology has helped us in not only doing the simple surgery, but the complex surgery in a very risk-free or preventive surgery. We can do it for that. If there's a bladder injury, nothing, as I have already told, repair with post-op indwelling catheter, which can be better, which can be very easily handled by the gynecologist for that. But ureteric injury, gynecologists are not very well acquainted with the procedure. I think there is a need of training by the urologist, from the urologist, and every gynecologist should know these not only the bladder but the ureteric injury, how to prevent and how to, if at all that is there, how to manage the ureteric injury for that, either implantation to the bladder or DJ stenting, which can be done, and this can solve the purpose for that. And whole procedure, if you do it gradually, slowly, don't be hasty in that, I think whole procedure can be really tackled, and in an inoperable case can be operable if the skill can be improved for that and updating your skill. So therefore the message, vigilance after anesthesia, the hypotension, need of meticulous surgical skill, avoid hasty dissection. Don't look at your watch and do the surgery. Never, in any case. Importance of light assistance and relaxation, as I have already told here, in this particular case, this is important. And always, prime importance is a preventive surgery. That is my belief. That is my philosophy. Preventive surgery is very, very important. Then you don't take credit of doing complications and managing complications. You prevent the complications. That's a primary importance. Recognizing the complications and managing, and don't ignore, if at all there is a complications, recognize, early recognition and managing it, undisclosed, unidentified thing and living, that will give it really a problem in the post-operative period, and that will be hectic for the patient as well as for the surgeon. And therefore, do a surgery good and forget about the post-op management. So post-op management, one of the most important post-op care is a good piece of surgery. That's important. Case 2, 60 years, para 4 with precedencia, planned for vaginal hysterectomy with PFR. After pre-op evaluation and investigation, decided to do under spinal anesthesia. And within 2 minutes of spinal anesthesia, patient was apneic. Suddenly after 2 minutes, he was apneic and comatose. I was really troubled. I was prepared with the gloves, and the anesthetist immediately intubated and ventilated, and pulse, blood pressure, oxygen saturation. Then after intubation and ventilation, pulse, blood pressure, SpO2 has stabilized. Within minutes it was stabilized, but it was intubated constantly. It was intubated, patient was comatose. Even I find the pupils are dilated also, not reacting to it. I thought it is gone. But believe me, the anesthetist assured me that this is a classical example of total spinal. So though it is very rare, but it happens with the high level. And majority of the cases, this comes to a relatively high level. It's not going for a total spinal, but relatively high level, where also the early symptoms will be there and you have to manage that. So whether now the question comes, I was also thinking, this was my first case and the last case, suppose I don't know whether in future I will get it further. Diagnosed as total spinal. Now the question came, whether to do the surgery or postpone, how to prevent it and how to manage it. So the question of prevention, whether to do the first primary thing is that the patient should survive. That's important. Then second is that the surgeries could be done. If the surgery is done, whether that could be done or not, I asked the anesthetist that no, you do it, there is not a problem. But I was really skeptical, but I had to perform it as per the anesthetist thing. I did it. And how to prevent it? How to prevent this position is very, very important. Total spinal, apart from the patient profile, there are some patient profile where the total spinal cannot be avoided, but majority of the cases, the head down drop tilt, more of the head down tilt can give rise to this total spinal, or in the high level, if they give it, then they give rise to total spinal. That can be prevented by proper identification. And how to manage, as this particular case, immediately you have to ventilate, put an airway, that's important. And immediately ventilation is there, everything can be settled for that. And how long you ventilate, that is uncertain. And usually I ask the anesthetist, how long will ventilate for that? He told that as long as the waning of the anesthetic agent will be there, and waning of the anesthetic agent usually come within 2 to 3 hours for that. And as long as this is the spontaneous is not there, I am not leaving the patient. I will have a ventilation for that. So perform the surgery, finished after 1 hour. Patient was under ventilator and monitor, still the same condition. Patient was still, but at least with the ventilation, the vitals were maintaining, pulse, blood pressure, saturation were maintaining. And I was just thinking and praying, God, what will happen? This is my first case. But after 3 hours, she recovered spontaneously. All of a sudden, the patient woke up. I was surprised. How is that? And transferred to the ward. I asked the anesthetist, you are right. I didn't expect that this could happen. He told that, yes, this happens, but you have to manage the case, maintain the ventilation, the airway, till everything is normal and the waning of the drug effect is there. Then there is not a problem for that. And that particular few minutes is important. Immediate putting the tube, endotracheal tube, and connecting to the ventilation is important for that. So the message, total spinal is uncommon, but everybody must have experienced. Level higher up, there are some cases which the level little higher up, it's not a total spinal and the patient is not comatose, but gives rise, the patient will complain of difficulty in breathing and saturation is falling. These are the cases, is a higher up. And here an oxygen mask support is necessary. If at all you need, there could be the intubation could be done. But primarily the airway is important, management of the airway. So managing the airway and oxygen support is the primary thing. Immediate management of intubation and ventilation will certainly stabilize the parameters. Once vital stabilized, surgery may be performed. And usually spontaneous recovery occurs after waning action of the drugs, Xylocaine or Pipivacaine, and that depends on the time. Case 3, 26 years primary infertility. In my case, I have experienced this. Primary infertility and underwent DHL, diagnostic hysterolaparoscopy. This is considered as a minor diagnostic procedure under GA. Surgical procedure completed, absolutely DHL normal, no surgical problem was there, and the patient was transferred to ward. After half an hour, emergency call from sister that patient is gasping, pulse and blood pressure not recordable. And then immediately in the ward, immediate laryngeal mask was given, LMA was given with ambu-bag ventilation. And ambu-bag ventilation was done by the concerned paramedical staff, ambu-bag. And we have got a training to the paramedical about the LMA also. And SpO2 improved, pulse, blood pressure stabilized after half an hour, patient under observation with oxygen support for 3 hours, stabilized and discharged after 24 hours. This is one case, and one case I lost. One case I lost in the medical college where the recovery room was not, the patient was in complete recovery and then transferred to the ward. And by the time the anesthetist reached or we people reach there, patient is gone. Already he is dead. So this is a very precarious moment. I still I imagine that particular fertility of mine. For no reason, she has come, a young girl under for infertility, she has come, and this is the situation for that. And therefore, incomplete recovery, very important to observe. And therefore, need for post-op recovery room with monitor. I made it a point that even if it is a small hospital, you have to have a recovery room with 1 bed or 2 beds, whatever is possible, with monitor. And therefore, with the one nursing people, assistants or paramedical people is there, they will monitor this with the monitor. After complete recovery, patient should be transferred to the ward. Don't immediately send from the OT to the ward. Remember this. This is a lesson which every gynecologist should learn it for that. So there is a really a need for a recovery room or a recovery bed, and early intervention saves life. And therefore, I always tell that please advise all the gynecologists, if in your hospital also, train all your paramedical staff in these particular adversities. They must be acquainted that, ask your anesthetist to train how to give an ambu-bag ventilation, how to give an oxygen support, how to even LMA can be done for that. This will really, because the time is important. By the time nobody is there, the nurse is there. She can immediately manage that and call somebody for help. So minor or major for surgeons only. We say that surgeons say minor or major, but for anesthetist, all are same, all are major. Even minor, we get a lot of complications, including the fatality. Case 4, 40 years, para 2, plan for lap hysterectomy. So prophylactic antibiotic amoxicillin sulbactam given 1 hour before surgery. After surgery, immediately after the injection, immediate tachycardia, hypotension, sweating, altered sensorium with falling saturation. Now bag and mask ventilation was given, hydrocortisone, IV was given, IV fluid started, and these are the cases. Think that it could be nothing but anaphylaxis, drug anaphylaxis. And there, the support is not by steroid, its support is not by mask, these are all supportive treatment, but injection adrenaline. Remember, we give an adrenaline 1 ml diluted in 10 ml of diluent, slow IV given, and within 15 minutes, gradually pulse rate settled from 160 to 130, then 100. So you think that the pulse rate is 160. How can I give an adrenaline? But this is the situation. This will just think that in anaphylaxis, tachycardia is there. If you give adrenaline, pulse rate will come down for that. So pulse rate, this is, remember, this is the drug of choice, adrenaline 1 ml. You push it directly IV for that. Nothing will happen. Classical picture of anaphylactic reaction. Adrenaline is the drug of choice. Other supportive measures are necessary, but it is an adjunct. And even seen after test dose. Remember, in test dose also, people must be in your hospital premises. This should be well communicated to your paramedicals also. Case 5, 25 years, abortion 2 with intramural myoma of 10 centimeter. And this was planned for lap myomectomy. And as usual, lap myomectomy, vasopressin 20 units in 100 ml dilution was injected. I usually inject this 100 ml dilution, 20 units, not more than that. And after 50 ml injection, the pulse rate bradycardia was 40 per minute. I made a routine. All I will advise everybody, while before injecting vasopressin, ask the anesthetist to see the monitor, whether there's a bradycardia or not. This is the only problem, is that the bradycardia will be there, and bradycardia less than 40 per minute. If it is going below 50, take it as standard. Don't go less than that. If it is 50, you have to give a atropine 1 ml, just IV given, and patient was stabilized. There are many cases which I have experienced, which this is a usual sequence. You caution the anesthetist why before injection of vasopressin, even if you do a proper diluent in a proper amount also, even there could be some reactions for that. Procedure was completed. So vasopressin message is that vasopressin is a panicky for I was just reading a literature of the endoscopic journal where it has been as if vasopressin is a really panicky for gynecologists for that. So many people have abolished by use of vasopressin for that. I think the prevention is important for that. So vasopressin, you can use it, but you must be very cautious about the use of that. Don't infiltrate directly into the vessel. If you infiltrate directly into the vessel, sudden demise will occur, sudden problem will be there for that. So that is the only situation. Don't infiltrate on multiple places. In one injection, you give it in one place, because multiple places is not only going to not going to help in surgery also. In one place injection, you give it. Whole 100 ml or 150 ml you can inject in one place. And therefore, in one place, you just aspirate whether there is a blood or not. If many people do not do that and they directly inject into the vessels, there the immediately bradycardia and immediately cardiac arrest will be there. So inform the anesthetic while injecting vasopressin. Correct dilution is necessary, and atropine is the answer. Don't wait for pulse rate to come down to 40 and give it. Minimum, I made a principle that 50, less than 50, I will give it certainly for that. This is a case number 6. Mrs. X, 48 years with heavy menstrual bleeding for last 3 years. Para 2, both LSCS, uterus is 16 weeks, endometrial biopsy, simple hyperplasia, sonographic evidence of multiple myoma uterus. And along when the sonography was done, the sonologist has seen the upper abdomen and it was a cholelithiasis. It was asymptomatic, but cholelithiasis was there, having multiple calculus. So when the report came as a multiple calculus, patient was really interested to do it both in one sitting for that. Also in the era of minimal invasive surgery, I planned for a combined surgery for lap call and hysterectomy in a single sitting. And my friend, a general surgeon, has come and he requested me to do the lap call first because of his another engagement. Another surgery was there. He told that let me finish the lap call and you will do the hysterectomy. And I agreed for that. Lap call was finished. And during the time of tissue retrieval, the gallbladder retrieval, patient had an intra-op cardiac arrest. Hysterectomy was postponed. Luckily, patient was resuscitated and revived and discharged from the hospital. Patient life could be saved. But she was discharged from the hospital after 3 days with the diseased uterus in situ for which she had visited me. It is very embarrassing that she has come with one problem and she has left, although her life is saved, she has left with the procedure which was not necessary, which was not giving any problem for that. And the diseased uterus was there. So I learned a message from that time. Combined surgery for 2 pathologies in one sitting is not contraindicated. Don't say no, I will not do. But in the era of minimal surgery, such procedure is beneficial for the patient, for the doctors, everybody. But the principle should be to take up the surgery first for which the patient has presented, not for the coincidental finding. From that day, I remember that even if I do a joint surgery for that, the patient's predominant symptom is upper abdomen pain related to cholelithiasis, and the uterus tumor is an incidental finding, then the surgeon has to do lap call first. But here, if the problem is basically with the pelvic part or the uterus is diseased, and incidentally we find that there is a cholelithiasis asymptomatic, first of all, hysterectomy has to be done. So this is the thing which I've learned from this. Complications, lap procedures. Now go for the lap procedures. We have divided into the lap, the histro, as well as the conventional procedure for that. And in the era of scopes and scanners, in the arena of high-tech technology or high-tech surgery, minimizing morbidity and maximizing results. This is to aim, but at the same time, avoiding complications. This is important. And not only minimizing morbidity, fertility should be zero mortality for that. So situation 1, 28 years conceived following infertility, diagnostic therapeutic histolaparoscopy, histoscopic cannulation overdue 14 days with spotting PV, UPT positive, sonography empty uterine cavity, endometrial thickness 8 mm, gestational sac left at adnexal region, no fetal pool, serum beta Hg is 1500, repeat beta Hg after 48 hours 1600, sonography cavity empty, gestational sac visualized left adnexal, no fetal pool, note, plan for medical management. An injection methotrexate 50 mg given, refused for hospitalization. So she refused for hospitalization, counseling done for immediate hospitalization and warning symptomatology, and advised for a review beta Hg and sonography after 1 week. What has happened? Presented after 3 days with syncopal attack and acute pain abdomen. Pulse rate is 140 per minute, BP 70/40, sweating, abdominal distension with free fluid in the blood. Planned for immediate surgery to the life-saving procedure and emergency procedure. Sonography is massive hemoperitoneum. This is a classical example of the ectopic pregnancy, tubal rupture, which in one of the episodes also, many ectopic pregnancy, different types of the ectopic pregnancy, I have also conveyed this. And this is an example where the surgical complications could be avoided by taking a certain steps for that. And that tips I will just convey today with that. So here, you remember that the patient is already in a peripheral circulatory failure, but you have to do an immediate intervention. And don't wait for blood. You ask the multiple unit blood transfusion, but don't ask for blood and then only you can go. Immediate resuscitation has to be done with the fluids. And then immediately you have to arrest the bleeding. First and foremost is that. And there was a really, you can see the left tube. There is an active bleeders apart from the hemoperitoneum. The left tube was bleeding. Left tube was bleeding actively. And therefore, this has to be tackled first. So arrest of bleeding is important because this is continuously bleeding and there is an active bleeder has to be really tackled immediately. And then peritoneal toileting and all that could be done. So this particular case, we learned many things for that. What we learned? Need for immediate surgery as an emergency, arrangement of blood or auto transfusion. If at all possible, this can use it. Pre of plasma expander and fluids, immediately you give it because the blood pressure was 70. Arresting bleeding is the primary surgical step. Reducing intraoperative timing of surgery. You have to finish the surgery as early as possible so that the anesthesia part and other things is subjecting the patient for anesthesia for a shorter period. And most important, when you see your patients like this, you lose your normal temperament and becomes altered temperament, irritable, nervous, stressed, and all that. But remember, these are the cases. You have adopted the profession. You have to manage yourself in addition to managing the patient. Cool temperament, steady procedure, confidence. If you have it, and that is the key to success for that. Maintain this particular key thing in all types of surgery, emergency surgery, and that is the key to success. Now, these are some of the complications in laparoscopy. When we put a varus needle and then go through that, and you find that these are all typical of omental emphysema. Luckily, you inspect whether there is an injury to the vessels of the omentum. There's nothing but here we find the typical omental emphysema all around. And here, remember that the faulty technique of introducing the varus needle, and varus needle here, the case must have been shown, the endoflutter must have been shown a level, in borderline level, like 10, 11, 12, like that. So definitely it has gone inside the omentum. It's not a free, unless the free flow is not there, and it is about the less than 8 millimeter intraperitoneal pressure. Don't try for the different level and just lift it. You have gone too deep into it, and lift it and find out the pressure, whether the pressure is less or not, and that by that you can prevent it further. Now this is another example. This is a classical example. You have done a varus insufflation. See the abdominal parietal. The insufflation, the distension is not proper, and you find whole of the abdominal parietal is full with the gas. Why this has happened? Again, this could be prevented for that. See, these are the cases where it can be easily prevented for that. So normally what happens? You put it and connect it to the gas. So normally it has not gone inside the peritoneal cavity, and you connect it to the gas. So when there is a suspicion, don't put it. Put the scope and find out whether it is extraperitoneal or not. And commonest thing is that you immediately put a scope and connect it to the gas. So remember, switch off the gas, and after procedure and all. And if something has happened, you go meticulously deep into it and find a cleavage line. And these are, although not fatal, but these are all complications which can be prevented. Otherwise, preperitoneal insufflation, extensive preperitoneal insufflation will give us a lot of postoperative morbidity, pain, and other things. This is another case. This somehow there is this particular case, there is no history of any surgery. Believe me, there is no history of any surgery. When there is a history of surgery, the recommendation is that the scar, the upper end of the scar has to be evaluated and give it at a higher level. But this particular case, luckily, this particular case has been given supraumbilical port, and this supraumbilical port, just had it been an umbilical port, it would have gone directly into the intestine. I always say that you are a lucky surgeon. This particular case, I think the luck is in favor of me, so that I could avoid it. Otherwise, if the gut is adherent directly to the anterior parietal wall like this, suppose there is a tuberculosis, suppose there is an adhesion, you do not know where is there. There is, even without a surgery also, there could be some adhesions for that. And in known surgery, if there is a scar, even in a lower segment cesarean, there could be adhesions in the upper level for that. And therefore, this scar is also there. Even if it is a subumbilical scar, the adhesion could be there at the higher level also. So there, remember that you put it at the higher level, either supraumbilical or a Palmer's port, and then under vision, you go through that. And here, it's a lucky that I have just gone above the intestine. Otherwise, if you have gone in the umbilical port, it is bound to happen. There is no way to prevent it. You can't know it. And many cases are there for laparoscopic surgeon. This accident can happen. You cannot prevent some of the cases for that. You are likely to go into it. Like here is another case where again you find in the umbilical port of entry, we find the whole of the intestine is adherent. I was thinking that I have already damaged the intestinal injury for that. Whenever I find this, I didn't attempt to go through that port. To confirm it, from the secondary port, from the lateral port, I introduced the hysteroscope, 4 millimeter hysteroscope. Everybody has a hysteroscope and laparoscope, 4 millimeter or 5 millimeter. If you have a 5 millimeter extra telescope, you can use it. Otherwise, you can use the 4 millimeter port. Here I'm in, and through that port, you inspect that. Whether you have injured the intestine or what is the extent of adhesion. That now luckily I find that only the intestine was there. With the port, there is some sort of dissection was there, and it was adherent to the port. You can see the port directly, the intestine was adherent. I think with the blunt dissection also, with that blunt dissection, just it went up, and luckily the intestine is free, and we could do a adhesolysis and rest of the procedure for that. So this is how we just do an adhesolysis, release the adhesions and the gut, and gut is safe for that. This is one of the examples which I'm giving it, the bowel adhesion for that. Now, this is a case where you can see the port, and you can find by second port there is a bleeding. This is a common thing. So normally you can locate the parietal vessels, particularly the infraepigastric vessels. You can locate it. In a thin individual is possible. In an obese individual is not possible, because you cannot see whether even if you locate the telescope there, point that it is not being seen. But this is a case where active bleeding is there. Most often the bleeding port side bleeding occurs from the main port also, and there is a little bleeding which ultimately controlled itself spontaneously. Here you also, if spontaneous control occurs in many cases, for that you just have it. But if it is not controlled and there, then this is the method you give it. You just do a port closure needle. As I've already told, the indigenous port closure. I've got it from PV Surgical, and you just a very simple thing. Earlier we used to put other types of needle, which is very, very troublesome. Or whole thing you can just do it and put it under vision, and the active bleeders are there, which you ligate it, and this is one way you can control the port side bleeding. 2, 3, you can give it as per the extent of the lesion, and then this is the management for that. This is another case. Where with the needle I've got it, and there is an active bleeding, and with the active bleeding and while introducing the port, this is you find that there is gradually the hematoma is increasing. Can you see a small hematoma there? And the hematoma is, at the same time, don't waste time, and immediately before any surgery, see the extent of hematoma is growing like anything. So immediately that has to be tackled. And if immediately you just do a coagulation, the things are controlled on that. Once the hematoma is extended to the deeper aspect, to the whole area, to the extensive area, it is difficult to control with this simple bipolar for that. So here, with the simple bipolar with the other port, you just coagulate and seal the bleeding, and everything will be settled for that in no time. So don't waste time in other procedures or don't start immediately control that and then go for the procedures, and then things will be all right for that. The bipolar can be a very good thing for control of the bleeding for that. These are all small things, but this matters. Don't ignore that and do it at the same time, and then the rest of the procedure you can do it, and the things will be absolutely all right. So port side bleeding, either you can tackle it with that suture or with that coagulation, the bipolar. Now, this is another, again, a hemorrhage, the omental hematoma. The omental hematoma could be from the varices or could be by the port. I think if you're increasing the larger diameter of the port, like 10 millimeter, the extent of the hematoma is much more, injury will be much more. If the port is there, if it punctures to the vessel, the extent of the hematoma is less. And this is one example where the vessels are, the omental vessels are involved, and most probably it is done by the varice needle for that. Or at best with the trocar of 5, I don't use more than 5 millimeter or something, unless it's a that 3D where the 10 millimeter is used. Otherwise, this is a omental hematoma. So now to intervene or not to intervene, identify the vital structures, and if it is not in the vital structures, it is the omentum, you can have a sealing with the bipolar vessels and control that. Or otherwise, if there is a spontaneous, I think there is no spread for that, no extension of the hematoma is there, just conservative procedures, and finish the procedure. At the end, you must observe whether the hematoma is increased or not, but it is static. At the end of procedure, you find that the same thing, it is not grown. So leave it as such. Don't do anything if it is not grown for that, because it's a closure to the bowel for that. So therefore, this particular case, many times our gynecologists see that and become really worried about it. Now, this is another case which I will show you. A patient where laparoscopy has been done, and you see at a much higher level the intestine, the gut, the mesentery, there is a gradually increasing hematoma, and gradually it is located in the mesentery of the intestine and involving both the sides. It is on one side, the other side is there also, but it's gradually spreading, and therefore the temptation comes. Now the decision is an important thing. When to arrest, when it's gradually increasing, I thought a superficial coagulation with that, so that it will not touch the gut, but it will it will prevent the spread of the hematoma for that. So there were gentle bipolar, I tried to control that, and the whole area of hematoma, I could control it, and without affection of the intestine for that. But this is a very, very important challenge, and I was also very much apprehensive in the post-operative period, what will happen, and really this is the thing. And more so, when there is, now its bleeding is controlled, we can find that this is good, but on other side also, the same thing happened. You can see the other side, and other side also, the same thing, hematoma is there, and other side hematoma, you have to tackle with that. Can you see that other side, the same area, the whole of the mesentery is involved. So these are the cases I was really suspecting some problem in that particular case. Ideally, these are the cases I think the resection anastomosis has to be done, immediate intervention has to be done. But if the bleeding is controlled and the patient is stabilized, the post-operative period was monitored, and a drain was given, and this particular case really there is no change in the color of the omentum segment of the intestine there. That is the only thing in favor of conservative method management. Otherwise, if the color change is there, that is the only thing. The color change is not there, kept for about a couple of about half an hour, observed for that, and there is no change in color of the. Otherwise, if there is a change in color, immediate intervention has to be done for that. This is one case which is, and believe me, this particular case, I put a drain the Riles tube inside it to know that there is. I was expecting some of the problem. Therefore, I hospitalized the patient for 1 week, and after 3 days, bowel moved and everything is normal, and I removed the drain, and after that, I discharged the patient. To my, I think I'm so unfortunate that the patient again came with bleeding, came with pain abdomen and abdominal distension after 1 week. Say 14 days after the surgery, she presented to me with the abdominal pain and distension and all that. There was a soft distension. I sought opinion of the surgeon, and the surgeon friend told that no, this is a soft adhesion, let us have a conservative management for that. But I insisted. I see that yes, this is a case where I should have opened that. And once the symptoms is there, after 2 weeks, you have to open it for that. And you have to do the anastomosis and all that. And otherwise, it's not, I will not be happy. And we decided for a laparotomy, explorative laparotomy, and we saw that that area segment, it was necrotic. The intestine was necrotic partially, and then we did a resection anastomosis, and patient has an uneventful recovery. Patient discharged after 1 week to the home. And therefore, these are the cases where it's a really it's a challenging situation for dissection, for decision making, and whether what to do and all that, and needs surgical assistance for the GI surgeons for that. Now, this is again a common thing. This is again a common thing. A diagnostic lab has been done, and you find the next day patient came that something is coming out for that. So from the main port. So main port at that time I was using the 10 millimeter port, and earlier there's a long back in 2009, and 10 millimeter port. And when I find the momentum is there, I just sealed it and reposed it in one case. And this is another case where the same thing happened. This is a lax abdomen. You can see that it's a multiparous women, and the same thing. The another case also, the same parameters is there. Now, I learned a lesson from that, and therefore I say always that why the problem arises because you suddenly remove the port trocar after the surgery for that. So don't remove the trocar suddenly after that, because the negative pressure is there, momentum can come out, and particularly for 10 mm port for that. So either you put the trocar, and then with the trocar introduced, you just remove it, or direct visualization. I always remember that all cases, direct visualization. While removal, I put the camera on and collapsed it, and all the gas making it out. Then under vision, you just remove so that under vision you can see the track, and at the same time you can know that there is no negative pressure and something is coming down for that. So this is how you prevent it, and that technique is very, very important to do it. Now this is another case. This is another case, previous history of some surgery, laparoscopic surgery, and this is a case of infertility, and the surgery has been done. This is a case of bicornuate uterus, and secondary infertility was there, and there is an extensive adhesion in the bladder, in the omentum, right from the umbilicus to the pelvis. So we dissected that, and suddenly we find that there is a wrong plane we have given going for that. And with a lot of effort, this happens at times when it is completely, the bladder was completely adherent to that omentum. Normally, a precaution has to be taken. Normally, the precaution has to be taken for the bowel, and particularly when it goes inside there, the dissection. You see, here the dissection would have been little other places. Now I find that the bladder is gone, and then this is a bladder injury which is there, and which could have been prevented a little because of the ignorance. This has happened, and this when I came, I told that yes, this you should have gone a little higher up for that, and luckily then I finished that. Don't worry, we will manage that. So the thing, adhesions would be there, and this happens in a teaching institute and training and all that, and let the trainee do the mistake, and they will learn from that. And bladder, this is as usual, when we do an open surgery also, when the bladder adhesion was there, bladder injury was there, we repair it in 2 layers at least. And here also the same thing, it can repair it with the 2 layers, with the 2-0. I've used that and repaired in 2 layers. Either this is a Vicryl 2-0, I've used it. You can also repair it. I have done the repair also with the barbed suture. Nowadays, the barbed suture is also important, because the barbed suture, the suturing is absolutely easier the knotting is not required and all that. But here it takes a little more time and a meticulous skill has to be done for knotting. And here, if you practice knotting, suturing, I think things will be easy and you can really do a good job for that. But these are the cases you need not open it and do a laparoscopic closure and then finish the procedure with the laparoscopy, the 2 layers. You can suture it and then you can have a post-op indwelling catheter for 10 days to 14 days and the things will be okay. And majority of the cases of this bladder injury, they're managed like that. And I think it's a gynecologist can manage the bladder injury, but a ureteric injury, I think you take help of urologist, learn it. And therefore, I made a point that I will be a learner for till my death. And I also learned many things from the urologist for that, starting from cystoscopy to the bladder repair to the ureteric implantation. All these I've learned it from the urologist for that. So the very important thing is that the 2 ends must be very well delineated. And this is closure in the first layer, closure will be there. And the whole thing, you just, the 2 ends make a stay also, or you can without, this is the thing, after the one stay, the other side, both sides has to be very well preserved and the angle must be noted very well. So beyond the angle, you take a bite to avoid that. And then the second layer, you do it and close the patient. And then subsequently with the watertight closure, everything will be normal for that. So these are the cases where immediately it could have been that the 2 things I will tell this particular case. One thing is that a little meticulous technique would have avoided this particular case. And that is very important that this could have been prevented because the dissection has gone more distally. If it should have been gone more proximally. This is a retrospective thought, of course, but this is essential for that. So this particular case, the suture material is Vicryl, and after the things are open, it can be managed by laparoscopy also. So laparoscopic procedure, you can do it, and suturing, you must learn, everybody should learn the suturing, art of suturing, and manage the case when, as and when required for that. So this is one layer, it is finished, and then the second layer, we do it and overlapping with that, and then you are being assured that nothing will happen. And with a good post-operative indwelling catheter and a drainage, things will be much more easier for that. So the knotting, everybody should learn it. And of course, I was initially doing this with the Vicryl, but particularly myomectomy and all that, when barb suture came, I always prefer this for myomectomy Vicryl. But for the bladder repair also, bladder repair Vicryl, this barb suture can also be used. That's important. And I've used it also the barb suture in bladder repair, and there is no problem for that. So this is the second layer, which is an overlapping layer, which I'm giving it, and that will strengthen the primary layer. And again, with the same 2-0 Vicryl, this is possible for that. So this is one of the cases where the bladder injury can occur in the cases of adhesions, and where you suddenly go and detect that there is a hole inside the bladder, and therefore this could be managed by the endoscopic suturing and the double layer for that. So this completes the procedure of the bladder repair injury after the 2 layers. This is second layer, the same thing, either this is overlapping that, and remember that with this overlapping, a good watertight closure can be maintained for that. Now this is another case where this is a typical chlamydia. There is a lot of adhesions for that, and both the perihepatic adhesions, and now we find that yes, focus on the pelvic side, and now we find the pelvic side, the tube were adherent, completely adherent to the gut, and while dissecting the tube from the gut, and this is a case of a past history of tuberculosis was there, and these are the cases where tuberculosis, you cannot find a good space and cleavage for that. So here, while inoculating that, there is a injury to the rectosigmoid, sigmoid column. So both the tubes are there into that. And while removing that, we find that there is a, I think the sigmoid injury is there, although the length is less than 5 centimeter, but there is a thing we cannot leave it for that. So here the option is either you go for a laparoscopic closure or go for a open closure. So laparoscopic bladder repair, I have shown you one case. You can go for the laparoscopic closure also, but I will just show that this particular case, this is the hole which you can detect it, and this I converted it into laparotomy, and just for knowledge sake, for my sharing to you, I'm just showing this technique that there is no hesitation in doing a laparotomy, but ultimately we want a good post-operative period, uneventful recovery. We want it, and we cannot leave it for that. These type of cases, when you just leave it, and post-operative morbidity and mortality will be there. And this is how you just alone you can do it without the help of the GI surgeon. You can close the sigmoid colon, because at the same sitting I did it, and there is no need of colostomy also with that. So what I say that a skillful surgeon, laparoscopic surgeon, can also do that. But believe me, this is particularly the case of tuberculosis, previous history of tuberculosis, and with the caseous material over the intestine, I didn't dare to do a laparoscopic closure. I converted it and did a proper cleavage, cutting at the edges, and removing the caseous material from the margins, and then do a closure for that. And that I find that is much more suitable than the laparoscopic anastomosis for that. So this is how you manage the gut injury for that. Now this is another case, ureteric injury, and here the ureteric injury is there, and this patient presented with the fistula, ureteric fistula, after 10 days of surgery. And these are the cases where I've already enumerated these few cases also during the time of my incontinence urological complications in the previous episode. But again, I will show that this particular case, how the ureteric dissection can be done and can be implanted to the ureter, to the urebladder, and little skill is necessary, but I think the urologist will teach you how to do that procedure. Now, most of the urologists have now converted this into the laparoscopic procedure, but because it's the remote complications of the hysterectomy following I feel that this could be the electrosurgical injury, which is lateral spread, which has given rise to this particular case. And I tried for the C-arm stenting for that. Majority of the cases, the stenting is there. In some cases, what happens, if there is a long segment is there, the complete avulsion of the ureter, the stenting is not possible. And these are the cases where it has to be done ureteric implantation. Otherwise, in most of the cases, 90% of the cases, the stenting is possible, and you do a stenting with the DJ stent under C-arm control. That I have already enumerated during my urological dissection for that. So this is how the bladder has been cystectomy is there. The DJ stent is there on either side. The DJ stent, I introduced it proximally as well as distally, and then this particular thing we did it, and you can do with the urologist colleague is very good, and the expert, the endoscopic surgeons are now there all over the country, and they can do a very good job and help you in this particular situation for that. So here the DJ stent has to be under stenting of this on either side, you do it, and then suture. These initial sutures, a fixation of the ureter, the distal ureter to the bladder or psoas each, and then opening the bladder wall, the cystotomy, you do it, and with the stenting, you negotiate, and the direction also anteroposterior very carefully you just monitor and suture it to the bladder, so that ultimately this could be a very good suture, and endoscopically the results are also much better nowadays following the surgery. This particular case, so here you can see how the things are there. You can go and suture it edge to edge you can go and complete the procedure with that endoscopically. So these are possible in the present context where the minimal invasive surgery can be also adopted for the implantation for that. Then at the time when it was not possible, now it was with the camera, with the suture, with the skill of the surgeons. I think it can be better managed with the endoscopy procedure for that. So this is one example I'm giving, a late complications of the ureteric injury where this could be very well tackled with that, and be very meticulous about that. And one of the advantage of this is that the vision is very good, and you can identify the edge to edge suture, and that is possible. That is possible for that. And this is really a nice. The other side TJ stand is there. Now after that, a segment of the ureter is incorporated inside the bladder, and therefore for the maintenance of the reflux, this is important. But the edge to edge is important. Edge to edge is important. You can do the procedure 3 or 4 sutures in the ureter. 4 sutures is enough for that, and that is going to solve a much more better procedure and good anastomotic with this. Then you close it, the bladder, and complete the procedure within a very short time for that. So the message I will give it that yes, we are afraid of the ureter always. The gynecologists are really ureterophobic. I think that should be there. If you are afraid of ureter, the chances of injury is less. That is certain about it. And therefore, this is the last stage where you find that the ureter has gone inside the bladder and there is no gap. This is the last stitch which I'm giving it. And this is the 4th one, which really is successful, that yes, we know that yes, it could be done. So usually this is either you can give an interrupted or a continuous all around, but interrupted is much more preferable for that. And now this procedure is certain that yes, I have done the good job and the patient will be all right. And at last, you just suture the bladder and complete the procedure. Now in the hysteroscopic procedure, complications of hysteroscopy. Complications related to anesthesia is one. Complications related to distension medium is another. Complication related to surgical procedures. These are the 3 main things in hysteroscopy. Apart from surgical procedures and anesthesia, another distension media is important. And therefore, the distension media long back we are using the monopolar, the underwater cautery where we are using, and therefore the glycine was the medium which was being used. And this was used in monopolar underwater cautery, and glycine gives rise to a lot of glycine toxicity, the ammonia toxicity, and a lot of fatalities also have been reported for that. And therefore, we have changed to bipolar, where the normal saline is being used and the bipolar resectoscope is being used. Now, the main problem of the bipolar is that the elimination of the ammonia toxicity will not be there. But don't think that bipolar is completely free of risk. Remember, in bipolar, if the amount of fluid absorption is much more, it can give rise to sudden acute pulmonary edema. So that this is the only thing which you concerns the anesthetist as well as you, that the patient will not have ammonia toxicity, but certainly pulmonary edema. The cutoff limit, if you go for in the glycine, if a fluid balance has to be maintained, and if the fluid balance is 1000 or more, in a case of glycine, it is toxic and you stop the procedure. And if it is more than 2500 per ml in normal saline, it should be, you haven't done the procedure, and risk of the pulmonary edema could be there. So these are the additional complications which you find it, and therefore the fluid balance is must. Either whether you are using a unipolar or you are using the bipolar, fluid balance has a mandatory thing. In one case, ammonia toxicity. In another case, it's acute pulmonary edema. And related to surgical procedures also, few of the situation I will just show. Mrs. X, case of RPL planned for diagnostic hysteroscopy and cavity evaluation. And therefore, this diagnosed as complete uterine synechiae. And when I came and I find that this is a thing which doesn't look like a synechiae, and then you see that this is another angle where you have gone to the different route and a false passage. You see this particular case. Initially, when you introduced it, you will find that nothing is visible and the whole thing looks like a synechiae. But just remove. I came and find out that yes, you withdraw the scope and find that there is a black hole above it. This is exactly looking like a synechiae. There are many cases where synechiae, the thing, and now withdraw it a little because there is a black hole above it, and in the above the false passage, this is a black hole where you again withdraw and go anteriorly and find the normal uterine cavity. Can you see that the normal uterine cavity is found, and that is a false passage, which is very, very common and particularly misleading for that. This is a consequence of the dilatation, wrong dilatation. So dilatation should not be forced, and if required, it could be facilitated by the misoprostol, or it could be done like this, a vaginoscopic hysteroscopy, where the vaginoscopic examination, the hysteroscopy, you distend the vagina with the vaginoscope and then introduce a small caliber of the telescope. 2.9 millimeter is much more better. You don't need to hold the cervix. Now I have negotiated with the external loss, then through the endocervical canal, and then I can see that yes, hysteroscopy. Normally the whole of the cavity can be very well seen after that. Then this is a very good thing by vaginoscopic hysteroscopy is an alternative solution for that. By that you can prevent. You can see the beautiful ostium on one side, the other ostium on the other side, and they complete the procedure for that. Now this is another case. 25 years, primary infertility. Yes, yes. Mrs. Y, 25 years, primary infertility, 5 years, planned for DHL, diagnostic histolaparoscopy. Diagnostic histoscopy. Visitor named Prakash. Visitor named Prakash. Mrs. Y, 25 years, primary infertility, 5 years, planned for DHL. DH cavity visualized and immediately collapsed. Rent suspected. When you do not find a good distension of the cavity and you suspect the rent and you confirm it by laparoscopy and you find that yes, fundal perforation, dye test, unfortunately. This is the case where introduce the hysteroscope. While introducing, you cannot see the image and you can find the rent. You can find the rent here, and to confirm it, put it laparoscopy, and the laparoscopy has to be done in a case of DHL. It was planned for that also, but unfortunately, this was a dilator injury giving rise to perforation for that. So these things can happen, and you can see that a lot of fluids are there, and you can see the fundal perforation by the dilator. It is a small caliber dilator of about number 4 dilator, and therefore the laparoscopy can confirm it. The active bleeding is not there. If there is an active bleeding, you just coagulate it, and peritoneal irrigation is done. Remove all the blood clots and fluids from that, and therefore this is one of the complications which can be prevented by the faulty negotiation of the dilator. This has happened for that. So either many people use the routine misoprostol for that. That's also good, that you give a misoprostol 4 to 6 hours prior to the surgery. And if at all this is there, then you just take if the laparoscopy is there, and you can fulgurate it and close it. Unfortunately, you cannot do a dye test here, but you hold it, grasp it with that, and can do the dye test. The blocking the perforation area you can do with that, and here the bipolar Bipolar, I'm using it to control the bleeding. Little bleeding, you can control the bleeding. But this is one of the iatrogenic complications of perforation of the uterus, which you diagnose it. If you do not diagnose, that could give rise to a lot of fertility for that. Situation 3, Mrs. C, 30 years, primary infertility, 8 years, case of bilateral proximal tubal block, planned for hysteroscopic cannulation. Teflon tip perforated the isthmic part of the left tube, relocated, negotiated under laparoscopic guidance, and procedure completed. Now you see, this is a case where the hysteroscopic cannulation is being tried, and this is one of the ostium in that. And this is the indigenous hysteroscopic cannulation set, where there are 3 elements. The inner stent is there, then the Teflon catheter or Teflon stent is there, which negotiates with a soft stent, which can negotiate with that. And subsequently, under laparoscopic guidance, you just negotiate to the ostium, and under laparoscopic guidance, you see what has happened. And here we have seen the laparoscopic guidance, it is straightened, and with the left tube, you can see this stent going on, and this is the procedure where you do the hysteroscopic cannulation, where in the proximal tubal block, this is the procedure which normally inspissated mucus blocks the level of the proximal tube, and that is the cause of the proximal tubal. It is a fibrotic, it cannot be done, and fibrotic is not amenable to treatment. But this case was really a case where under vision you can demonstrate that something has gone inside, and we cannot find that it has gone inside the tube. I cannot locate where it is, and just introducing it, and after some time we can find that yes, it has find a different way for that. So hysteroscopic cannulation initially is a very good rewarding surgery for that. But here, can you see that this is gone inside the isthmus? So beyond the isthmo-ampullary junction, it has perforated, and this inner Teflon catheter, normally the design is such that from distal to proximal, the softness varies, and but unfortunately this has happened. This is one of the complications which I have faced. I have negotiated, I have relocated it, and again finding out it has gone to the wrong cleavage, it's not through the proper lumen, and now it has relocated with that, and again introduced with the proper place for that. And now you can find that it has gone through the proper tube in the proper place, and you can find that the whole thing can be out, and under laparoscopic guidance everything is visible. And if there is a don't put more of force for that, because more of force application will really damage the internal tube, and now we can find that the whole of the catheter has gone out of the fimbrial end, and the cannulation is completed. But that particular segment, it has ruptured it, but fortunately it has for fortunately it is only possible relocation. And other times relocation is never possible. You postpone the procedure and do it in another sitting for that. But this is a unique case where I have kept it, and you can see the conformation of the dye, spill of the dye here, and partially block the tube there. Otherwise, that will leak through that particular puncture. So this is one example where this is possible. Mrs. D presented with persistent vaginal bleeding following TCRS 8 hours prior to after surgery, and how to approach and manage. This also I have told that yes, electrosurgical session, I have told that this is a cutting current and pure cutting current, and when there is a bleeding, you just touch it with the coagulation current and blend current, and that is possible. And this is the procedure. Although it's a fibrous band, at times it bleeds much, or in a case of myoma, the bleeding is much more while doing a resection. These are the cases where the primary arrest of the bleeding is through the touching it through the blend current rather than the cutting current. You change the current, identify the spot, localize where there is a bleeding, you touch it for that. Otherwise, you can use the Foley's catheter, pediatric Foley's catheter, postoperatively and arrest the bleeding. Normally, this is not being necessary if you were very careful in coagulating the bleeding points with the coagulation with the blend current for that. This is again a case of primary infertility, 5 years, planned for diagnostic histolaparoscopy. Histoscopic view is completely different, and you see that this is the histoscopic view. Histoscopic view, I was surprised to find that this is the histoscopic. She has come with infertility for 5 years, but there is something space-occupying lesion in the cavity, and that lesion is some physiological lesion. It's not pathological, and it is an iatrogenic complications which are made it for that. And therefore, routinely, even if you take a proper menstrual history is important. Now a beautiful gestation sac is visible. Inside the gestation sac, the fetus is visible. And I was really shocked when I find the beautiful intrauterine pregnancy in a case of primary infertility for 5 years and taken a history of last menses 15 days back. And you should be very, very cautious about it. At times what happens, they mislead the last normal menstrual period or the last normal menstrual period, or that has to be found out. If there is a spotting, you are more confirm about it. Otherwise, you lose that. I was very much disheartened, given tons and tons of progesterone, and pray God that this could be, please preserve this pregnancy for that. Unfortunately, God is great, and the pregnancy continued and delivered a male baby. I think I was very happy that this particular case, in spite of all the complications, she is being rewarded with a baby. So this is one of the cases where the complication can occur. So the lesson is, be very, very sure that she is not pregnant. If you have seen earlier and recorded that, and after 2 months you have given a history, again reevaluate that particular case for that. Now, there are other complications like the open cases. Finished the laparoscopy as well as histoscopic procedure. This is a bladder injury by conventional surgery, either by hysterectomy or during cesarean, which is not a very difficult procedure. And this double layer closure can be done, and you without the assistance of the urologist also. Every gynecologist can make a repair, and with the 2 layers, you can repair it, and post-op drainage is very good for that. So this is a conventional procedure which I am demonstrating with that. Now, this is again a ureteric injury, and this is post-op ureteric injury, which is repaired by laparotomy. So one case I have shown you how to do a repair with the endoscopic procedure. This is by laparotomy. By laparotomy, you can see that if particularly those who are not well versed with that laparoscopic procedure, you can do a laparotomy also, and you can see the distended ureter here, ureteric dissection, and then go distally where the blockage is there and where is the problem during the primary surgery of the ureteric. Either is a ligation, most probably it's a ligation injury. It's not a thermal injury. It's a ligation injury where this is the consequence in that. And the same procedure you can do it, dissect the ureter, and the ureterobladder you implant it for that. The procedure is all same, and here you say release it. That is the point where the ligation is there during surgery. All of this by Bowery's technique, you can do it, and ureteric implantation with the same thing with the seed. You don't skeletonize it, and you can introduce it to that bladder and reimplant, as I have shown you in a laparoscopic procedure. And this is the same thing you can do it by making a hole, a tunnel into the bladder, so that to preserve the backflow, or that is important, so that the backflow is not there, the reflux is not there for that. So reflux is very important for ureter. So to prevent that, you can do it. And now the bladder is being cut, and the same procedure you can do it with implantation for that. Now, this is another case. While doing a surgery, in a case of endometriosis, during a surgery of hysterectomy, we find avulsion of the ureter. So what you do, in the same sitting, you do it, and the same procedure you do it, and implant it with the ureter, with the bladder. So this is one case where it's not a remote, immediately the diagnosis and recognition of the ureteric injury during the time of surgery in this particular case. So I want to show the varieties of cases, the long-term and immediate surgical complications or delayed surgical complications, thermal as well as non-thermal ureteric injury for that. I think many of the cases have been presented in my early episode, but this is again a rehearsal, or while doing a complications, I think I thought it's better that I will show this particular cases, few cases of mine, which I have noticed and complications which I have faced for that. Now, this is a case again, where the case I still remember, this is a case of vaginal hysterectomy, which I was doing it. It's a case of 12-14 week size uterus. I was very aggressive in doing that particular case. I should not have been more aggressive, but subsequently it's a craze of surgery and vaginal surgeon. And this is a case underwent the myomectomy, abdominal myomectomy earlier, nulliparous, and uterus was again 12 to 14 week size. And I thought I will do that. And hysterectomy was completed. It was uneventful. On hysterectomy in the last, before closure of the vaginal vault, I could, that everything, I didn't detect that there is a rectosigmoid injury. The rectosigmoid injury, when on suction, before closure of the vagina, suction, I found one brinjal seed. So I detected a brinjal seed, and that has saved life. And I salute the brinjal seed. That brinjal seed was there. Then I was very meticulous in that. Where from the brinjal seed is coming? It must be some gut. And I could find an injury in the rectosigmoid. Bowel was well prepared. There was nothing coming out. And therefore, the rent was identified. And through the vaginal route, I started repairing in 2 layers for that. And patient has an uneventful recovery. So this is a case where the complications can occur, but you have to diagnose and treat. Had I not diagnosed it, non-recognized case, it would have been a terrible post-operative problem for that. And therefore, I saluted the brinjal seed that you have saved my life for that. So these things can happen. Be very meticulous in finding out if there is a suspicion of the gross adhesions of the rectosigmoid. You be very careful in finding out that. And the lower part, it can be very well detected by the PR examination by putting a glove, but higher part is very important. And if there is a suspicion of adhesions in the higher level, you just find out some other methods for distending the rectum and then finding out that whether the gas is coming out or not. But this is one of the examples which any gynecologist can do it. You don't convert it into laparotomy and you can do the procedure. Patient has an uneventful recovery for that. This is again a gut injury, electrosurgical complications, and the vaginal hysterectomy has been done and electrosurgery has been done. And subsequently, on 4th day, the patient came with a distension. Patient was discharged, again came with distension, abdomen was distended, tender, fever, all these. Then I suspected that this could be some GI problem for that. And therefore, we did the laparotomy with the help of the surgeon and could find that there was a rent. And that rent, this is the rent which I find it, and that rent most probably is due to the rent in the intestine. Is most probably, I thought that it could be the electrode which has touched it. Or second option is that because the electrode touching is less, because we are very careful in packing, giving a pack, and under pack and under vision we coagulate it. The most probable is that the upper pedicle, while coagulating, it becomes hot, and that hot upper pedicle might touch that intestines and cause that injury. And since that time, I usually what I do, I sprinkle the water to cool down the upper pedicle, and if necessary, I will take a pause of 1 minute to cool down and then leave it. Otherwise, it will touch and all that. This is one lesson I have seen, that I have also shown this in electrosurgical burn injury, and this is one case where I've told the company people also how to avoid lateral spread and how to avoid the local rise of temperature. These 2 things has to be taken care of, and so that the complications can be avoided for that. Now, after the intraoperative complications, post-op complications, few post-op complications, because this is a headache for all gynecologists must have faced different types of complications. And these are the few post-op complications which I will just convey to you. 54 years, obese, hypertension, diabetes mellitus with carcinoma endometrium stage 1, underwent lap hysterectomy. After 24 hours, patient was dyspneic, tachycardia, blood pressure was 90/70 with oliguria and occasional cramps in the long fields. And what could be the diagnosis? What could be the cause after 24 hours? It's a obese, hypertensive, diabetes mellitus, and after 24 hours, why this has happened? It could be early septicemia, because septicemia, remember, there is a duration. Septicemia, the earliest septicemia occur in urological case, within hours, within minutes. But in gynecological case, it takes little time. About third day, on 72 hours after, sepsis could be there for that, unless it's a pre-existing sepsis. So early septicemia could be one of the reasons. It could be internal hemorrhage. Is it an internal hemorrhage or early pulmonary embolism? Now I did the parameters. Hemoglobin was normal, 10.6. TLC was 14,000. Chest X-ray, there was mottling patches, both long fields. And therefore, the third diagnosis was thought of as the first. The early pulmonary embolism could be there. Oxygen, oxygen mask was given. Low molecular weight heparin started. 40 units subcutaneous BD. Antibiotics changed to meropenem. Hydrocortisone was given. Patient improved significantly after 24 hours. Vital was stable, and therefore I thought it is confirmed. Low molecular weight heparin was continued for 5 days along with antibiotics, IV fluids for 48 hours. Stabilized patient was stabilized after 48 hours for that. So the message is that pulmonary embolism not uncommon in pelvic surgery, and prophylactic low molecular weight heparin, there is a place. And my recommendation, particularly for pelvic surgery, if the obese patients weight more than 90 kg, you give a prophylactic low molecular weight heparin. Either a cesarean or a pelvic surgery, you give it for that. This is my protocol for that. And remember that I have been beneficial for that. Then second indication, those who have a history of deep venous thrombosis, it has to be routinely, prophylactically, before surgery and after surgery for at least a couple of days, 3 to 4 days is essential for that. So these are some of the lessons learned. And I say that there is a place for prevention of the pulmonary embolism, because pulmonary embolism is very, very fatal. Luckily, this patient had not a very fatal pulmonary embolism. Otherwise, immediately they die. Pulmonary embolism, immediately the long fields are gone and they die. Early intervention improves the condition for that. And therefore, these are the cases when you suspect, start the heparin or low molecular heparin, whatever is there. Heparin is also effective for that. And therefore, preventive in a pelvic surgery, weight is important. Obesity, history of deep vein thrombosis, and some of the ethnic population. I think these are the cases where you do start the low molecular weight heparin. Post-op complication, again, 45 years, underwent vaginal hysterectomy. Long back, I think, I remember this particular case 20 years back. 45 years underwent vaginal hysterectomy with PFR for presidencia. Third post-op day, tachycardia, hypotension, oliguria, pyrexia. And on examination, pallor was mild, increased temperature, mildly altered sensorium, abdomen, there is a soft distension, and we changed the antibiotics to piperacillin tazobactam. CBC was raised, neutrophil was 84%, and patient didn't improve on fourth post-op day even after this injection. And the consultation of physician was done. Physician told that yes, you give an anti-malarial. Quinine, you start it for that. I was really skeptical. I thought, no, you give a quinine, it will be all right for that. But at that time, ultrasound was in preliminary stage. Only there was no PV, the transvaginal probe or transperineal probe. It was only linear. It's not a curvilinear, linear probe. And that revealed an echogenic area in the pelvis. That revealed an echogenic area in the pelvis with fine echoes. So I thought there must be some collection in that. Why the patient is not improving if it is a sepsis? So what I did in the OT, I just put a speculum, and over the bulge, I find out that yes, in the anterior repair, where the repair was done, I put the artery forceps and punctured it, and suddenly 500 ml of thick pus was drained. It was foul smelling. Treatment continued. Believe me, patient improved remarkably after 12 hours. Vitals were stable and discharged after 1 week. So this is a case where septicemia is common, but
post-op sepsis has to be considered in some cases, but whether it's need for likely septic focus, if there is a septic focus, whatever antibiotics you give it, the procedure is drainage. When there is a pus somewhere, it must be drained, and surgical intervention has really a benefit on that. Only medical intervention doesn't help in this particular case. Gross septicemia or sepsis or peritonitis can be relieved for that, but frank abscess or collection, it can't be controlled with that. Now, this is the third post-op complications. 42 years para 2, both LACS, AUB-A adenomyosis, underwent lap hysterectomy, and it was a doctor's relation. And on third post-op day, pain abdomen, dyspnea, pulse BP within normal limit, chest clear, SpO2 normal. For abdomen, I find that there is a soft distension. And third post-op day, bowel sound was sluggish, urine adequate, CBC was normal, and I put it basing on the suspicion of the subacute intestinal obstruction. I thought it is a subacute intestinal obstruction, nasogastric aspiration, IV fluid given, antibiotics changed, but didn't improve after 24 hours. Rather, symptoms aggravated, more of pain. The patient frequently complain of more of pain. Pain is not relieved for that. And therefore, surgical consultation was done, and surgeon saw, and he advised for an abdominal sonography. It is absolutely normal. There is no collection, nothing like that. And the surgeon told that nothing is found, but the patient is having symptoms and there is a soft distension. So I think benefit of doubts, decision for surgical exploration could be helpful. If we lose that, otherwise we are losing the patient. And therefore, I was also a little nervous, and decision for surgical exploration, if the condition, I told that let us wait for 2 days and then we could find out. If the condition doesn't improve, then, but after 48 hours also condition doesn't improve, rather the symptoms persisting and aggravating, and it is deteriorating. The symptoms are more, pain are more. And then I was just sitting with the patient and the husband. Husband was also very much depressed, seeing the condition. I was also thinking that exploration is necessary. I have counseled for exploration. Then husband gave a history that my wife was taking antipsychotic drugs for last 3 years, which has been stopped from the day of surgery. That was not known to me, and advised. Therefore, I thought that let us start again, and advised to restart the same day. I told that you start the antipsychotic drug immediately from today onwards. Believe me, I was surprised. Remarkable improvement after 24 hours. Ambulating, removed nasogastric aspiration, IV fluid, indwelling catheter, and discharged after 4 hours, 4 days. I think the message is, it is not uncommon, but can happen. It is a lesson to me. Disproportionate signs and symptoms often confuses the surgeon. Here we are not able to corroborate or correlate any of the symptoms and signs to the progression of the disease. And importance of history taking is important. I had not taken a proper history. It's my fault for that. Antipsychotic treatment and unnecessary IV fluids, nasogastric aspiration, antibiotics, surgical consultation was again a retrospective thought. It was not necessary for that, because this is one of the situations where disproportionate signs and symptoms, it could be thought of functional. But in post-surgery, we cannot think of functional from the beginning for that. Now, ladies and gentlemen, lastly, I will say some of the pointers or some of the parameters of the patient really puts that under headache, or how to manage that. So, basing on that, you analyze what is the condition, whether surgical intervention again post-op is necessary or not, or whether it can be managed medically. These are the main factors for that. And if necessary, if you think that it is not related to obstetric gynecology and think that it is something of a physician's domain, you or a neurologist domain, you just give a consultation for that. One is very important, is a pulse rate. Pulse rate is very, very important. And remember, pulse rate and blood pressure, these are very important. Blood pressure may be in the lower range. If the pulse rate is normal, I'm assured about it. If the pulse rate, there is a tachycardia with the borderline hypotension, I'm really bothered about it. Dyspnea, saturation, dropping of the saturation. Many people do have that. And you have to rule out the lung fields and lung problem, chest problem for that, and manage accordingly. Either maybe due to pre-existing diseases in the chest, that could be there, or perioperative. Many people do have this dyspnea, breathlessness, and diminished oxygen. Pyrexia, again a common thing. Pyrexia, reactionary temperature on the second post-op day is very common, but persisting pyrexia with rigor on chill and suspicion of the septicemia could be done if there is other symptoms like a abdominal tenderness, loose motions, and all that. Urine output. Important is urine output. I was very happy that if the urine output is normal, even if there is a hypotension, I am not bothered about it. That's important. And in some cases, when you find oliguria, immediately after surgery, you find that the urine output is less. And believe me, you think that I have damaged something, ureter, I have ligated or something like that. But the urine output, there could be anuria there. Urine output is scanty, the oliguria, and the color is normal. If the scanty urination is less, majority of the cases, what we find that if the duration of hypotension during intraoperative period is more, that will give rise to a temporary the kidney damage, and that is called acute kidney injury. That gives rise to the elevated urea and creatinine. So the temporarily the kidney is being damaged, and therefore this urine output is less. And they respond very well to Lasix and the fluids. You give a fluids and Lasix, and you think that the next 12 hours the urine output is good. But the color is important. If the color is frank blood, interfere immediately. There could be some damage to the bladder. Immediately you interfere that. If the color is blood stained, then you are I think better that yes, the color is blood stained and there is a history of bladder adhesions for that. And in some cases, while dissecting the uterovesical pouch or a difficult adhesions in the uterovesical pouch in a previous surgery, the color could be blood stained. But frank blood, remember, this is very, very important. Frank blood, anuria, be cautious about it. Anuria, before stamping it as anuria, exclude that there is no blockage of the Foley's catheter. Many cases there is a temporary blockage. You change and the abdomen is distended. You change the catheter and everything will be all right for that. Abdominal distension. I think this is again a distension which you really is an objective finding. Distension should not be there. And if these parameters are there, post-operative, the headache is there for that. And the general rule, remember one thing, particularly in a minimal invasive surgery, the day by day, hour by hour, minute by minute, patient should improve. If the patient doesn't improve, day by day or hour by hour, think of something and intervene there. So that is the procedure, that is the philosophy. You make it and have an analysis what could be there. Bowel movement, either the loose motion or the flutters is not passed. Both are problematic for that. Altered sensorium. If it is an altered sensorium, I think you can think of some other non-gynecological, I think consult the physician, neurologist for that, and altered sensorium. It could be there are many cases where the malaria, the falciparum malaria is there following surgery. It could be a coincidence for that also, giving rise to altered sensorium for that. Or some of the brain with the coincidence of something related to some neurological problem, and that can give rise to altered sensorium. Pain. I think therefore pain management has to be there for that. And pain management, and if the patient is having a pain, it will also give rise to tachycardia. And tachycardia is also, if you give a analgesic, tachycardia will be vanishing and normal pulse rate will be there. Headache, vomiting, loose motion, and these are the things which also, vomiting is a common thing, gastric upset, which is a common thing. It should be relieved with a conventional antiemetic for that, but vomiting at times is a really troublesome thing. Headache, the spinal headache is most common amongst the gynecologists, a cesarean or an open surgery or a vaginal surgery. Commonly the spinal anesthesia has been given and the headache is very common. And there are measures to prevent the spinal headache by using a small bore needle. Nowadays, everybody is using a small bore needle, and all theoretical things about the bloody patch and all that are there. But at a headache, more important is lie down a position, more of fluids, and the position important is don't have an ambulation for that. More often they should lie out. In sitting position, there will be more important than more. And some of the vomiting also, you find out that if it is not relieved with the conventional antiemetic, then consult the gastroenterologist or physician for that. Loose motion is an early sign of the septicemia or pelvic collection can give rise to loose motion, or commonly you think that the antibiotics causing the loose motion. If the antibiotics, you give it switch on to the antibiotics can, particularly oral, after oral, the third day you start oral and they give rise to loose motion. Majority of the cases is attributable for that. But if there is additional symptom of pain, distension, leukocytosis, and the pelvic tenderness is there, then think of pelvic peritonitis giving rise to the loose motion. And then the paresis. One of the common things we gynecologists notice is paresis following the vaginal surgery and laparoscopic surgery. And this paresis could be a form of neurotemesis or axonotemesis or neuropraxia. I think these are the cases mainly because of the position of the patient. The positioning, the stirrup are defective, have a good stirrup and a support to the calf muscle. And prolonged duration of surgery in this position can give rise to different types of the paresis, which takes time, but it is automatically correctable, and it's not a permanent permanent problem for that. There's not a long-lasting thing, but at times it takes few days to correct that paresis for that. So prevention is important, the position is important, undue abduction and the long duration of surgery and hanging stirrups rather than supporting stirrups are the cause of this paresis. So these are the postoperative parameters of significance. This has to be needs to be addressed scientifically and analytically, not alone, but in common combination, and then reach at a diagnosis what could be the complications for that. But these are real headaches for the surgeon. And I, as a surgeon, I feel that when the patient is absolutely normal after surgery, I am very happy about it. If this patient is having a oliguria or anuria, my urine stops and all that. If she is having a fever, I don't have a good sleep, sound sleep in the night. So that's very important for that in postoperative parameters. So the final words, ladies and gentlemen, minimizing complications and maximizing results are the real truth. We must minimize complications and maximize results. Decision and dissection. It's not a dissection which is important. Decision is to be there if you designate yourself to be surgeon. Take and touch. You cannot say that technology has advanced. We'll all do with the technology. Touch is also important, and combination and blend. There is a need of take and touch. There is a need of the blend of take and touch. There is a need of the blend of will and skill. Surgical will, surgical courage should be there. Courageousness for surgery. I think that by that you can be a good surgeon. And acquiring a skill from the different methods. There are methodology of acquiring skill, surgical skill. I have almost in my first lecture, I have told about surgical skill transfer in 21st century. There, I have covered everything, how to acquire a skill from the person, from the internet, from the books, from the journals, from the person. But main skill is the mentor. The mentor is important. And without a mentor, you cannot be a good surgeon for that. And assimilate, see the surgery of various different types of surgery and assimilate, synthesize, and make your own blend for that. And then only you can be a good surgeon for that. Dividends versus confidence. Always have a confidence. Don't have a dividends for that. Don't think that it's a commercial aptitude for that. It's a service attitude. God will help it. You do not have a malified intention and have a confidence in it. Confidence is very, very important to finalize this. And lastly, labor and luck. You should labor hard for that. And luck is there. Ultimately, the destiny is there. Even if you, in a simple case also, you are face complications where you shift the blame from you to luck. Luck factor is there. God is not happy with me, and that's why. But I think main is the labor. And the definition of labor, I always tell, labor, luck is labor under correct knowledge. And that is the definition of luck. LUCK is labor under correct knowledge. But ladies and gentlemen, ultimately what is that? Ultimately the result counts. It boils down to result. If the patient has come to you, they come with pain and living with pleasure, nothing like it. And that gives the maximum satisfaction as a surgeon, as a human being to everybody. Thank you very much, ladies and gentlemen, for giving me another opportunity of 2.5 hours with you people for that. Thank you.
Thank you very much, sir, for your great deliberation. And words are not enough to appreciate the efforts which you have taken. I mean, non-stop speaking for an hour, 2 hour, 2.5 hour. I mean, this is not really possible for everyone, but you have that particular skill and stamina. We salute you for that, sir. Thank you very much for your deliberation.
Thank you.
And sir, as usual, there are several questions which we would like to address with your help. So should we start with the question?
Yeah, I'm ready.
See, Dr. Tanzila Nazir from Anantnag, she's asking managements of PPH on table.
Doctor, I have intentionally left a PPH for that. An obstetric part will deal with this some other thing. But see, PPH on the table. Remember, PPH on the table, we know that PPH could be traumatic, PPH could be atonic. And you must identify what is the type, what is the cause of that immediately. Because many cases which I find, they think that it's all cases of PPH is due to uterine atony. So uterine atony PPH, thinking that uterine atony, tons and tons of ecbolics have been given for that, to control that. But they ignore that there could be a traumatic PPH for that. I have seen one case where I have given an example that the labor room in the medical college, in the labor room, the duty, assistant professor on duty saw a PPH, then gave all medicines, and it is not being controlled, then decided for emergency hysterectomy. And on that day, my routine OT was there. I was doing a vaginal hysterectomy there. And she asked me, sir, this is the case where I'm going for a hysterectomy. I told that you just find out what is the cause and all that. But to save life, immediately gone a hysterectomy. But even after hysterectomy, the bleeding continues. Then he called me, sir, you have to come. Then I went there, put a speculum, and find that there is a spiral tear in the vagina. And I thought, see, doctor, this is the cause. You should have put a speculum in the from the first attempt rather than doing a hysterectomy. And I started doing it. There was a long spiral tear, and I stitched it completely, lacerations of the vagina. I stitched it. Bleeding was controlled, but patient was had a cardiac arrest, and we lost the patient. I think these are the cases where you must be very, very cautious, whether it's a traumatic PPH or a atonic PPH. If it is an atonic PPH, a lot of ecbolics are there. We are routinely giving active management of third stage of labor by giving oxytocin, and a preventive is important. Majority of the PPH are created by us. Believe me, that I always say, again, the same principle of pack, press and pray. You are on the table, you are doing a cesarean, deliver the baby, and after the delivery of the baby, before as soon as the head is being delivered, give 10 units oxytocin to the drip and 10 units intramuscular. I always say 60 seconds before the complete expulsion of the fetus. And then after that, don't manipulate, wait. Many people have a habit of finishing the surgery quick and doing a manual removal of the placenta and all that. I always say, wait, pack, press and pray. And therefore, the uterus is contracted and gets a time for contraction. And after that, spontaneous expulsion occurs. And the whole thing, the uterine wound is absolutely dry. And this is the situation where you can prevent it, even with oxytocin. There is no need of the higher prostaglandins and all that. Of course, in some cases of expected bleeding, like a hydramnios, like a twin pregnancy or multigravida, you have to give the next step is a better uterotonic like prostaglandins agents, and that solves the purpose. But surgical management of the PPH is a different part for that. So if it is not being controlled and it's definitely atonic, it's not a traumatic PPH, the compressive sutures can be of help to you. And if the next is about hysterectomy, if the paras lady and the bleeding is more and patient is in shock, if the paras, she has a baby and the patient's age permits, I think better to do an early hysterectomy than rather to do a stepwise devascularization as taught in these books. Stepwise devascularization. You train first do it, intrailiac you do it, then you do the hysterectomy. By the time hysterectomy you do a hysterectomy in the cadaver. So I always feel that this is only in a case where in a young age or a primary gravida, the compression methods and alternative uterine conservation procedure has to be done. Otherwise, if at all it's a multigravida or if at all it's a placenta previa accreta and bleeding, you immediately don't take a time, immediately do it, and without blood you can finish that. And obstetric hysterectomy can be done with that. I have shown during the time of cesarean also how to tackle the atonic PPH. So the cases where the atonic PPH in a young, then you can give a compression suture, but don't ignore the traumatic PPH also. That is my concern about it.
Sir, the next question will be asked by Dr. Sanjay Navle.
Thank you, sir.
Yes, Sanjay.
Sir, the next question is from Dr. Savita. She is from Sangareddy, and she is asking regarding the tips in case of lap hysterectomy.
So you have gone one step ahead. Complications, you want to have a uncomplicated lap hysterectomy. Tips of that. I think simplifying lap hysterectomy, all surgeries should be, basically I feel that all surgeries should be made as simple as possible. Don't make surgery complex. That's important. And nowadays, the gadgets are also there. The visibility, the number one is a vision. Very important is a lap surgery, is the vision is there. A good camera should be there. A good assistant should be there. And lap hysterectomy is not a very, very difficult case. I say that if out of all the laparoscopic surgery, I always say, let me observe an endoscopic surgeon operating on endometriosis, grade 4 endometriosis, conservative surgery for fertility promoting surgery. Then the rating of the endoscopic surgeon can be, not by lap hysterectomy for that. But lap hysterectomy, basic principle is a good, the gadgets are necessary. The uterine manipulation is the next part for that. And in the gadget, the vessel sealing device plays a very important role. Or you can combine with the ultrasound technology, and then you can do the job for that. But hemostasis is very important, and dissection of the bladder is very important. And don't give a laterally. What happens? Majority of the cases, the complication occur in the uterine. You try to make it have, I think, avascular at the close end to the uterus. Go closer to the uterus. If the problem occurs, if there is a bleeding, you go more lateral. Then there is a bleeding, you go more lateral, and there is a chance that ureteric injury would be there for that. So the technology, the vision, the assistant, and the electrosurgical equipment can be a boon for laparoscopic hysterectomy for that.
Right, sir. Sir, there is a query which is coming from Dr. Purnima Nepram from Imphal.
Purnima is always saying, always.
Yes,
very
sir.
good.
Every time, sir. Yeah.
Welcome, Purnima. I'm very happy that you have not left any of the episode.
Sir, she's asking about preoperative thromboprophylaxis. What is the best medicine and how many days before operation to be given?
Well, I have told that preoperative thromboprophylaxis, previous history of deep venous thrombosis, if there is there, weight more than obesity, weight more than 90 kg, pelvic surgery, and obstetric cesarean section. These are the cases, and ethnic population, of the ethnic population, family history, and all. These are the cases needs a prophylactic thromboprophylaxis. Now, it should not be given for a more period. It should be given for 3 to 4 days is enough. And there are cases where there is a previous history of thromboprophylaxis, DVT, and a case of recurrent pregnancy loss. We use during pregnancy also enoxaparin, and that cases you continue. Otherwise, you just continue the enoxaparin up to 34 weeks. Those are the cases you continue till delivery. And in the gynec surgery, you start at 24 hours before. That is enough for that. Don't start much before because the bleeding will be more. So you start 24 hours before and at least 2 to 3 days, 7 to 2 hours following surgery. That is enough. 4 to 5 days is enough. And the dose could be 40 to 60, the 40 units BD, 80, 60 to 80 units per day, subcutaneous low molecular weight heparin, or heparin if you want to give it 5,000 to 7,500 unit 8 hourly. You continue with that. But the main problem, I will prefer the low molecular weight heparin because the monitoring is not required. Otherwise, you have to monitor the PT, APTT while giving an heparin, and you have to give 3 times for that. And here, at least once or twice you can give it. You can give it 60 units daily or 80 units daily or 40 units twice daily for that. That suffices.
Sir, next query is from Dr. Manju Sharma. She is from Delhi. She is asking if there is a pressure pack, then how to confirm it won't rebleed, and so how long should we wait after removing pack before closing? So this is the query.
Now, pack, I am not very much in favor of pack. So this pack which I told, it's a temporary period. Pack, press and pray. That means you immediately put a mop while doing an open surgery, or if you are going for the laparoscopic surgery with a small gauge piece, you just make a pressure out of it. And the pressure, should you press it for 5 minutes, that is enough for that. Many people do not have patience for 5 minutes. They just pack it, they just press it, and just after 1 minute they remove it, and again there is a bleeding for that. So press, if there is a generalized bleeding, you press it for 5 minutes. I think within 3 minutes everything will be okay for that. That should be the procedure. But the pack which you mean is a vaginal pack, particularly the vaginal hysterectomy. We give a pack for prevention of the reactionary hemorrhage. Believe me, this was earlier when I was about 15-20 years back, I was also adopting the vaginal hysterectomy pack for that. And that books also write that that prevents reactionary hemorrhage. But that is not, that is a thing which I don't believe. Primary arrest of bleeding is important. You just don't care of the primary bleeding and say that I'm giving a pack and that will take care of that. No, that is not the principle. Primary bleeding should be absolutely normal. And believe me, in vaginal surgery also, I don't give pack. So pack is not the answer. And in generalized bleeding, particularly for immediately control of bleeding in a generalized bleeding during the time of primary surgery, there is a place that you pack and press for a few minutes and then remove it. It is not a vaginal pack for completing. Vaginal pack or uterine pack, if there is a bleeding and all that, uterine pack for surgery, that I believe that yes, Foley's catheter, uterine pack can help for that. But for hysterectomy, after hysterectomy, you give a vaginal pack. This is not really sound, which earlier people have thought, and we were also using the pack for that. I will give a primary importance to the primary surgery for that.
Sir, Nasrin Ashfaq from Hyderabad, she is asking how to manage scar ectopic with live 7 weeks pregnancy, what precautions to be taken, what could be the worst complication in it?
Well, during ectopic, we have exhaustively discussed this scar ectopic. You can listen to that episode also, where the scar ectopic. The diagnosis is very important, and therefore now, because of the good high resolution sonography, scar ectopic is diagnosed more often. And particularly if it is a 7 weeks live pregnancy, there is no place for the medical management for that. If scar ectopic, if the live pregnancy is not there, the HCG level is not very high, I will prefer a medical management for that. And here there are two approaches. Either laparoscopically, you just remove it and stitch it, that's one. And hysteroscopically, many people have also tried to remove it, and that depends on the thickness of the muscle. If the thickness of the muscle is more than 3 millimeter, less than 3 millimeter, don't attempt hysteroscopically. It will just damage the urinary bladder. If the thickness is more, then you can do with the hysteroscopy, but there is a risk of bleeding for that also. So there you do a laparoscopic approach, cut it and refresh this wound, scar, and then stitch it for that. That could be a wise episode for that. Otherwise, if medical therapy is feasible, you start with the methotrexate
And I have a couple of cases I have done with that. But be sure that it is a scar ectopic. It's not a cervical, the product of conception which has dislodged from the uterine cavity to this scar ectopic.
Right, sir. So the next query is is coming from Dr. Nandini Chakraborty Bhattacharya from Kolkata, asking when to wean off the patient from aspirin in case of emergency LSCS for hypertensive disorders.
Well, when emergency arises, you have to continue, because the last, you do not know when this is there. But this is mainly for elective cases. If you are going for elective cases, you have to stop the aspirin 7 days, at least 7 days before. Normally in a case where we continue the aspirin, and in a case where it should be aspirin, and particularly in combination with heparin also, in recurrent pregnancy loss we give it, and that we continue up to 34 weeks normally. And those cases where there is a DVT, then history of DVT, then we continue whole of the pregnancy till delivery and after delivery also. That is very clear about it. But aspirin in other cases for PIH prevention, you cannot say that after 34 weeks I'll block it. You have to continue that. And if at all you have planned for elective cesarean section, at least 1 week before you can discontinue that. And if it is an emergency, you have to do it. With suppose in the morning she has taken aspirin and she has a leaking or hypertension, you have to do it in the evening. And I don't think there is any problem for that. I don't think there is any problem. I have also seen many cases where with aspirin also, people say that there is a more of bleeding for that, and you have a measures to control the tackling the bleeding. That is not a problem.
Right, sir. So there's a similar query coming from Dr. Anjan from Baripada, Orissa, asking which is better, LAVH or TLH?
That's $1 million question you have raised for me. So the sequence of event, when it came, LAVH was the first. When laparoscopic approach was decided, LAVH was the first thing which become very popular. Why? Basic thing you remember as a surgeon. It is easier to approach from above up till uterine. Up till uterine, it is very easy by laparoscopy. After that, the problem arises. Whatever problem arises, uterine, ureter, Mecken rods, bladder, all these will arise after that. And if you go by vaginal route, any hysterectomy you do it, it is easier to approach vaginally up till uterine. So lower part is very easier. And that is the main concept of LAVH. So complications wise is less, and approach is much better. So that you do laparoscopic hysterectomy, and it should be very clear. There is some indication of laparoscopic hysterectomy. In a normal case where vaginal is feasible, don't do it. It's always vaginal. But when there is a pain, when there is an adenovirus, when there is an adhesion, I think you have to resort to laparoscopy. You should not be a craze for doing a vaginal also in that particular case. And in that particular case, choice is there. That if you believe the concept of, if you can go for up till uterine, you go LAVH, and then the rest of the cases you do vaginally, then you can do it. And in a previous cesarean also, those who are expert in vaginal, they prefer vaginal, because separation of the bladder is adherent to the lower uterine segment, and in the case of previous cesarean. And from below, it is better to separate because the bladder injury is less. But laparoscopic surgery, if at all you are going for laparoscopic dissection of the bladder, you go from lateral window and come to the middle point, because middle there is a adhesions for that. So it depends on the skill of the surgeon. It depends on the aptitude of the surgeon, or depends on the mood of the surgeon. I think it is just a bias. It is just a bias that people take a credit that I am doing a TLH rather than LAVH. LAVH, if you do, many people say that it is a low ability vaginal hysterectomy. LAVH is low ability vaginal hysterectomy. TLH, as if it is a panacea or a supreme case for that. It depends on the case for that, whether you are going for that. But TLH is not a very difficult surgery for that, and there must be some indication for that. I believe personally, I am giving a postulation for that. If
majority of the cases of TLH, the delivery of the uterus is again by vaginal route. Whatever TLH I have done, my restrictions of TLH are there whenever the uterus cannot be delivered by vaginal route, cannot be delivered. So in a case of say rigid, I think narrow vagina, previous surgery, nulliparous, even nulliparous we can do vaginal also, but these are the cases where the vagina doesn't admit more than one finger, and particularly for the mentally retarded children where we do the hysterectomy, those are the cases we do it completely from above and remove the tissue from marsullator. That seems more logical and scientific. That seems more logical and scientific. But however, you can do the LAVH or lap-assisted vaginal hysterectomy or TLH according to your choice for that.
Right, sir. Sir, Dr. Rita Malik from Delhi, she's asking what to do to prevent post-operative sinus formation at UMB port site. In few cases on biopsy, it was found to be tuberculous.
Now, this is again a post-operative sinus is a complication, delayed complication of laparoscopic surgery. And fortunately, it has come down. My personal experience, I will tell. Way back in 1990s, when I started the laparoscopic surgery, this was really a headache for me. And believe me, every alternate patient do present with the sinus. I was really a headache for me. Every alternate patient do have a sinus. Then I analyzed what is the problem, whether the sepsis was not there. But I found everything for that. Then the main reason I could find that the duration of surgery. And the beginning phase, now the surgery which was taking laparoscopic surgery, which was taking half an hour, at that time it was taking 4 hours. That was the beginning. And the port movement for 4 hours give rise to lipolysis, and that is the cause of the port infection, which is being, because the sepsis and other things are uniform for that. Some people believe that it is the chemical which is responsible for that, the Savlon, the Lysol, the sterilizing solution, these are responsible for. Not at that time we also cleaned it. After that, lot of very meticulous cleaning also we used it. We were really bothered about it. So in that particular case, I find the majority, I believe that the duration of surgery and more frequent movement of the trocar occurs as long as the 4 hours period more often it is there. That gives rise to lipolysis and infection. That is proved. Then number one.
Yes, sir.
But rest of the cases now, suppose that is excluded, the role of atypical mycobacteria. This is absolutely correct. This is absolutely correct. Not only in laparoscopy, in cesarean also I found out there are persistent sinus, and I have also mentioned during my cesarean episode also. There are a number of the persistent sinus there for long months and years also. And those cases, even port also, I have tried AKT, AKT4, thinking that it could be atypical mycobacteria, and it works. And it helps in many cases for that. So these are the two possibilities.
Right, sir. So there is one more query which is coming from Dr. Aarti Nayak from Bhubaneswar, asking that like she might be having a patient with a bladder injury. So the bladder injury case was caused by electrocution. Should we excise the margins before suturing?
Now, Aarti, this is a very good question for that. Now, bladder, the question initially also I was thinking that the margin which is cut has to be excised for that. But when I saw the urologist operating on the bladder, and particularly for radical surgery, I have seen many of the very good competent radiologists, open surgery also. They cut it with the unipolar cautery. They cut the bladder with the unipolar cautery and stitch it. Then I changed the opinion that it is not necessary for that. I don't think that is necessary. But the only thing is that
this scar is important. If there is a previous scar, I think that has to be excised.
Right, sir. So these many queries are there, but I must tell you there are plenty of appreciations from various sides, sir. At least I think I should mention the names of the doctors who are real big fan. Everyone is a fan, of course, but like, Dr. Rita Malik, Dr. Sanju Haldar, Dr. Lalita Shukla, then several others, sir. I mean, there's long list.
Thank you very much for this continuous program, and these are all familiar names I'm hearing every time, every episode. That signifies that you are so much concerned about this eGurukul.
Correct, sir. Correct.
And we'll continue that. 16 episode, I thought that, yes, I don't know what is the next episode which is going on, but somebody asked me whether, I was also thinking that everything has been finished. What else is left behind? Everything, all focus thing I have completed, but still many things could be done. We can discuss a very, very small aspect in a more elaborate manner also in future.
Sir, your magical box is so elaborate. Things keep on coming out. All right, sir. Thank you so much for your patience.
Thank you. Thank you,
queries, sir.
Thank you, sir.
That you are always with me for all episodes.
Right, sir. Thank you so much, sir.
Thank you.
Thank you for your presence.
Thank you.
Support, you can stop recording.
Recording stopped.